SmileUSA Academy's presentation, which was given as a webinar on May 27, 2020. The information in this webinar is subject to change because of the dynamic guidelines and new protocols that keep updating. I wish to provide a brief introduction regarding the reason behind this presentation. This webinar was conceived by our superstars of our Maxi course in India, who all came together and collaborated and came up with a list of problems we are facing with the COVID-19 pandemic. What is brilliant is that they asked the right questions so we can get the appropriate answers. They were not looking to find solutions to problems that did not exist. Here are some of the commonly asked questions. Should we wear PPE? And if so, what should we have? Should we have a single use, or should we have a full length gown? Or what type of mask should I use? Is it a 3-ply surgical mask, KN95, or is it just N95 8210, or is it N95 1860, or a cheap replica of the N95 which also says they are N95, whereas they are not all the same, and we better know our basics before we start purchasing these products. By merely purchasing an N95 does not mean you are ensuring safety. These N95 masks need to be closely fitted, and as you can see, the internal architecture is different for each of those designs. The 8210 is the standard type, whereas the surgical respirator is 1860. Should we get these fancy HEPA filters? And if so, what should be the filtration strength? Is it able to suck any of the viruses? If the patient is sitting here and the patient sneezes, is the HEPA filter able to draw all the droplets from the patient to this filter? Will it be effective against droplet nuclei? Is it going to be effective against a wet, contaminated droplet nuclei? How long should you have this filter changed? What is the efficacy of these machines? If so, what is the total area that is effective in? Or should we get a UV filter or UVC lights, which is supposed to kill bacteria and viruses? Or perhaps maybe we should open the windows, have the air conditioning running, and have a fan that's going to act as a return. Or should we have expensive HEPA filters into our returns of our operatories? What should I use? Is it hypochlorite? Is it hypochlorous acid? Or is it sodium hypochlorite? Or is it calcicide? Or should I use a good hand sanitizer and then use the spray on all the surfaces? Or should I spray the entire room between patients? And if so, how long should I wait between two patients? Or even better, should I fumigate this entire room with one of those fogging machines? Will that be effective? While the above is okay to explore, the pertinent questions to ask would be, what is the kind of disease we are dealing with? How were the pandemics dealt with in the past? What is the mode of transmission? Contact, airborne, droplets, fluids. What is the lifespan of the virus to be alive outside the body? If that airborne disease actually goes and lands into a surface, what is the viability of that virus outside the body? What is the possibility of the antigenic shift in the virus? What's the construct of the virus so it can be addressed with the appropriate agents? Do we get antibody generation and immunity? Or will this virus behave like a seasonal flu so that we have to keep worrying about it year after year? And will there ever be a vaccine? If I know the enemy, I can defend myself. Why build a fortress when the enemy can fly? Why have cannons when the enemy goes underwater? This is what is happening currently with our profession, which is baffling all of us. So the knowledge about the enemy is the first thing to understand before we have our ammunitions lined up. I think we are getting it all wrong. We're working backwards. Hence, the virus appears to be more ominous. This webinar is meant to shed some light into how we keep ourselves safe and healthy and still treat our patients, because we cannot continue to be in fear and not go to our offices to see our patients. Whilst less than 0.8% of the population are affected and suffering, we are allowing the remaining 99% of our population to get sicker with poor oral health. I am presenting materials based on peer-reviewed journals, CDC and ADA recommendations, and EPA approvals. Please fact check these and don't make your own assumptions. It is up to you to infer. Please do not misrepresent or be misinformed by what is said on social media, because it will only create more fear, anxiety, and confusion. I also urge you not to copy, edit, or reuse this video. Please feel free to email me and keep the truth intact. And thank you in advance for your cooperation.
Good day to all of you. Thank you for tuning in, and it gives me distinct pleasure and delight to address all of you. It's on a sad note that I present to you our last few sessions of these webinars. We had a total of 15,000 attendees, cumulative attendees, over the past 2 months, ever since the lockdown started in March 16, 17. This is our 40th webinar of the season, and we have provided over 60 CE credits throughout the world. We have participation all the way from Fiji Islands to Hawaii, and we are spanning at this time over 18 time zones. And we are really happy to have this panelists. We have Dr. Varun Acharya and Dr. Ned Bande, who will be moderating the session. And this is going to be an interactive program. I would like to start off by thanking all of our supporters throughout the world. I would like to start by thanking my coordinators in India, my co-director, Dr. Badivel Kumar, my coordinators, Dr. Arif and Dr. Syed Khalid Altaf, my co-director from UAE, Dr. Ned Bande, and of course, my co-directors in the US, Dr. Bart Silverman, Dr. Jack Pierre Marty, Dr. John Minichetti, and the list goes on, without whose support this entire educational endeavor would not have been possible. So why are we here today? We are here because we are at the crossroads of a pandemonium. We are here because we want to get some answers, we want to get some insights as to where our profession is going. The world has seen itself come to its knees. There's not only panic, there's utter confusion. In the United States, almost 49 states have opened up its doors to essential services. Dental practices are now open in the United States, when we are seeing death rates approaching 100,000. We have over 2.5 million cases being reported, and worldwide, we kind of occupy a third of the total mortality rates. What does this reflect? Has the United States been exposing itself to a disease process that it cannot control itself? Or is the disease process that virulent that even a developed nation like the United States is finding it hard to curb the spread of this virus? So we are going to be discussing a lot of these issues today. It's a hot topic because it's affecting all of our lives and practices. It's also affecting our staff. And I want to welcome all the staff and team members who have joined us in this webinar, and many of the auxiliary staff who have tuned in to get some more information as to what they should do to protect themselves and their patients and so on. So this is going to be an interactive session. We have polls, we have questions that you can ask, we have some experts who we have lined up. We have an OSHA expert who is going to be presenting to us. And let's make it a truly interactive session that is going to be evidence-based. It is not eminence-based or eloquence-based. It is going to be based on facts. I'm not an expert in epidemiology. I'm not an expert in infectious diseases. I'm not an expert in OSHA regulations. But what I am is a committed professional who's out there to get some evidence-based answers to the problems that is affecting all of us. My job here is to produce the evidence that is going to support our practice. It's going to help our patients. It's going to protect our staff members. It's going to help our community at large. And the profession cannot crumble for lack of information. Our ignorance cannot be the reason why we should be failing. And if we succumb to this disease, it only shows our weakness, not our strengths. So we are going to give you a lot of handouts. For those of you who are interested in downloading, I have more than 15 handouts. So as the program goes, you are free to download the PDF. It is in your control panel, and you can get this either emailed to you or you can download it. It's for use. It's for sharing all the information. And many of what I'm going to present is actually going to be from the source itself. So I've given them due recognition, and thanks for sharing much of the information that I'm going to be providing you. So how are we going to deal with this enemy? Why was I keen on presenting this? I am practicing implantology, right? My practice is limited to prosthodontics and implant dentistry. Why should this affect me that much? This is the reason what prompted me to give this webinar. I'm dedicating this webinar to my sister who passed away just over 2 months ago. My last contact with her was on March 6th. I traveled with her to a lot of these southern Indian cities. I flew with her and I took her to a lot of these places. And around March 6th, the word corona was barely sketchy. We had heard of efforts by the Indian government to fly many of our Indian residents from Wuhan back into India. Many of our students shared their information. In fact, one student in particular is from Fiji, and his brother was flown in from Wuhan. So I thought, it's not going to affect India that much. It's far away. So this is my interaction with her on March 6th. I bid farewell to her. I took my flight and came back to the US. She developed some symptoms. She's a kidney transplant patient. She developed symptoms on March 9th. Symptoms because the physician thought it was an infected fistula. Of course, she was leading a very normal life. She had a transplant in 2010. For 10 years, she enjoyed good life, almost like a normal human being. The first symptoms occurred on March 9th. And the suspicion was that fistula was probably infected. So she was put on IV broad spectrum antibiotics for a week. You name it, she got it. The best of the doctors in Chennai treated her with the utmost care. Her vascular surgeon, her nephrologist, they were monitoring the case 24/7, and they could not get her fever down. So antibiotic after antibiotic was given, and she was getting frustrated to a point where she had to be admitted on March 23rd. Her symptoms got worse, and I was on the phone with the treating physician, and they said they had no reason why she was having hypoxia. Her oxygen sats dropped to 70%. That's critical. So they asked if she could be on a ventilator. The hospital did not hesitate to put her on a ventilator. Right? This woman is made of steel. Every time she goes in the hospital, she comes out. She's undergone umpteen number of surgeries, so we thought this is just another event and she's going to come out smiling. Little did we know that there was this is serious illness that had overtaken her. And she passed on the 24th. At that time, COVID was not very popular. In fact, the diagnosis, we had no tests. There were no antibodies. We didn't know what the symptoms were. So how could we recognize this? Because she didn't show classical signs and symptoms of COVID, which was not even being published in India at that time. So now in retrospect, there's no other reason why she should be gone in a few days other than blaming it on COVID because of her exposure, because of the immunosuppressant medication that she was on. So this is very dear to me, and I've spent the past 2 months researching every single article that there is to figure out how we can control the spread and how we can get back to normalcy. I'm also going to dedicate this to my wonderful staff who stood by us. This is the first day of the lockdown. We donated almost 40% of our PPE to hospitals. And what did they have? They had nothing. There was a major shortage of PPEs. So we gave our gowns, gloves, masks to Mount Sinai Hospital. And we're very thankful that we did this. And they just came and helped our patients. Our office was closed for about first 2 weeks, and then we were open for emergencies. Thanks to our governor, we are open for essential services and for routine work as of yesterday. This is the wonderful team that's been helping our patients, and these are the people who is making us look very good. So I want to thank each and every one of my staff members for being courageous, being knowledgeable, and being there to help our patients in need. So looking back into the history of where this all started, basically surgical field became popular after Shushruta was being quoted repeatedly in plastic surgery literature as well as for surgical procedures. And if you look at the environment in which it was performed, it was probably the lowest point of asepsis. Right? Didn't know anything about bugs or drugs. And then we has performed a pedicle flap to reconstruct a nose, and that was the first reported surgical incidents. We also need to thank Leeuwenhoek. This is the reason why we know about bugs. His studies on microscopes showed us the first evidence of microscopic beings that humans' eye could never see. So he is considered as the father of modern microbiology in 1673. These are the pioneers who really made a big change in our lives. The birth of microbiology and bacteriology, starting from Lister, Koch, Cohen, these are the pioneers who really taught us how to keep ourselves safe. The birth of vaccination also started evolving from Edward Jenner's work with the cowpox. And slowly we started to see these miraculous changes in medicine with improvement in mortality rates. This man in particular, Lister, Joseph Lister, he can be considered as the father of asepsis. It's because of him that most of the surgeries were successful. This is dating back to 1865. I want you to focus your attention on this particular area right here. What this is a spray. It's a phenolic spray. Okay, the phenols were introduced in 1865, and this is the steam machine that was spraying phenol while the patient was getting operated. The concept of washing hands, he taught people how to wash hands. Otherwise, the surgeons never washed their hands because they wanted to look bloody. The more blood you had in your hands and your shirt, the better surgeon you appeared. So it was peer pressure. So many of them resisted washing their hands between patients. So he was the first one who said, you know what, guys, you need to wash your hands, and maybe this phenolic compound is going to improve the morbidity rates of surgery. He started the germ theory. Martinez is the guy who now is seeing viruses. He really didn't know what they were, but he had a filtrate. So he had subatomic microscopic filtrate wherein the bacteria was collected and there was something else that was going on through the filter. And he just called it as a soluble living germ. Little did he realize that what he discovered was a virus. And this is dating back to 1898. So when you look at the history and evolution, it's amazing how some of these pioneering works have changed human lives. So let's understand the difference between a bacteria and a virus. It looks very germane, right? We studied this in 12th grade, or we studied it in biology 101. It's very easy to differentiate between a bacteria and a virus. But what does it mean in terms of infection? In terms of its vitality, it's unicellular. A bacteria is unicellular, whereas the virus is an obligate intracellular pathogen. The size of bacteria is in microns, well, probably about 2 or 3 microns, whereas a virus is in nanometers, the power of -9. The proliferation of a bacteria is through cell division. You all know about mitosis, whereas the proliferation of the virus is through intracellular replication. So it has to enter a cell to be able to multiply itself. Either it happens in the cytoplasm or it may happen in the nucleus. So this piece of protein, which is a simple strand of DNA or an RNA, may or may not have a plasmid or a protein wall, has to enter the cytoplasm to be able to get into the system to replicate itself. Once it builds up, it bursts, and that's how it starts to spread. The treatment for bacteria infection is antimicrobials and antibiotics. And what do you think is the treatment for a virus? Antiviral medication, that's it. And there has been a lot of talk about hydroxychloroquine and azithromycin. Those are antibiotics. There is no way they will have an effect on viruses. We've also seen a lot of media hype about different compounds using smoke, using heat as a way to destroy this virus, and most of them are baseless. In terms of viability, a bacteria can stay on for days, whereas a virus would probably stay on for just a few hours. And there have been reports stating that the virus can stay on for about 72 hours. Well, that again is difficult to prove. You need a wet medium. You do need some kind of a capsule to enclose the virus, because if it's free floating, there's no way that can have an effect. So you have to be careful about smooth surfaces, doorknobs, and so on. Strains, it's very stable, right? If it's a bacteria, if it's tubercle bacilli, or if it's going to be a streptococcus, that is not going to change. You know these particular antibiotics for that bacteria, right? We know that if you get pneumonia, there is a specific antimicrobial you can use to control pneumonia or to treat pneumonia. Whereas when it comes to a virus, there's something called as an antigenic drift. It keeps changing its form, because you can see those keyways on the top. It's very easy for a DNA strand to mutate itself and change it. So that's why it's a moving target. And that is why each year we have to get a flu vaccine, because the strain keeps changing. We have no way of controlling the strain. And that's one of the reasons why this COVID is becoming difficult to manage, because we've seen so many strains change. It used to be in the elderly, then it's now in the adolescents, now it's affecting the infants, and then it's going to be on healthy patients, and then we see it for immunocompromised patients. So its presentation is varied. It came as a respiratory disease, and then now we see it as a gastrointestinal disease. So its presentation is varied. There's another reason why we are finding it hard to fight this. So when you talk in terms of the cell sizes, I want you to know what we mean by microns and micrometers. That's a coffee bean. That's about 12 by 8 mm. All right, so when we go deeper into the magnification, we will see that you're now getting to a sesame seed, which is about 3 into 2 mm, so 6 millimeter, okay, cubic millimeter. A grain of salt from a salt shaker is about 0.5 millimeter. You can still see the grain of salt. The amoeba proteus, that's a prokaryote, is about 500 microns. The paramecium is about 200 microns. A skin cell that exfoliates from your skin is about 30 microns. The human egg is about 130. So that's why it's easier to do IVF, because a human egg is fairly larger compared to the other cells like erythrocyte or osteoblasts. The skin cell is 30 microns. The receptors in your rods is about 2.5 microns. And you get to a sperm cell, it's about 60 microns. That's why you can take a 60 micron cell and put it into a 130 micron egg. So you see the chromosomes, it's about 7 microns. That's about really microscopic. And red blood cell is about 8 microns. So when we talk about the micron range, you still can see these particles of cells. The E. coli bacterium is about 3 microns. That's very small, right? So you can see how a bacteria can affect cells. It has to be smaller than the size of the cell. The lysosome in the cell is about 1 micron. Now we get into the virus particles. The measles virus, which is an exfoliating virus, is about 220 nanometers, subatomic particle size. Then you have the phages, that's about 200 microns. We are getting closer to the actual screen. Okay, so it is getting, the HIV virus is about 130 nanometers. The hepatitis virus, Hep A and Hep C, is 45 nanometers. All right, so you could see how this would go further and further. And the ribosome is about 30 nanometers. The hemoglobin molecule is about 6.5 nanometers. And then we get into the smallest of the particles that can be ever measured through an electron microscope. You need actually a very special microscope. The glucose molecule is about 900 picometers. The carbon atom, the basic element of structure, is about 340 picometers. So this is the relative range of the cell sizes. So you can see some of these atomic particles. When we talk about aerosols, you'll start to realize how fallacious some of those concepts are. So when you look at the particle size, you should be able to think about what do we mean by filtrates. How is it going to affect some of these masks? What size should I have for the mask? What should be the specification for a HEPA filter? What kind of antiseptic should I use? What kind of disinfectant will break through the cell wall and kill the bacteria? So this is why it's important to have a scientific basis for our understanding, so we just don't appear foolish and do things arbitrarily. So these are the types of viral diseases known to mankind. This is the respiratory virus. Why is this important? Because only if you understand the types of viruses would you be able to know the pathogenesis. So if I am going to be wearing a full bodysuit for a virus which is not going to be communicable through body contact, then it would make sense. But if I'm going to use a method which is not going to address the problem, what's the point? So you don't see bodysuits being worn for a HIV case, right? So this is why it's important to know which organs are affected with the viruses and what's the nature of communication that points to the type of intervention that we can implement. So the respiratory virus is the flu, SARS, adenovirus, MERS, Middle Eastern Respiratory Syndrome, and rhinovirus. So part of that respiratory spectrum is COVID. The GI, the so-called stomach flu, is the rotavirus. Right? You wouldn't be wearing masks to control the stomach flu. You wouldn't be wearing gloves if somebody had stomach flu. Neurologic, right? Patients suffering from polio, rabies, meningitis. So those viruses affect the neurologic systems. Exanthematous, these are the ones that shed off. chickenpox. That is more dangerous because they are the true airborne viruses. They are up in the air and you can inhale them and you can contract measles. So you've seen these kids getting, they may not even touching each other, but it's an airborne disease, right? So that's how exanthematous viruses behave. The hepatic viruses are A, B, C, and D. Some of them are bloodborne, some of them are transmitted through the orofecal route. The cutaneous ones affect the warts, right? The genital warts, HSV1 and 2, and the molluscum contagiosum. So these are all the cutaneous viruses. The hemorrhagic ones are the mortality will be increased in those viruses. The Ebola, the dengue, and the yellow fever are all part of the hemorrhagic line of viruses. The oncologic virus is HPV, EB virus, Epstein-Barr virus, Burkitt's lymphoma. So if you see the origin of some of these cancer, there is a virus etiology. So knowing the etiopathogenesis of the virus will give us some kind of a clue as to how to approach these diseases. So now let's look at the evolution of the plague. The Great Plague of London. So we're talking about epidemics and pandemics in the world. The Great Plague of London was 1665 to 1666, the so-called bubonic plague, transmitted through the rats. There's always a vector that is being used to transmit diseases. Then the Great Plague of Marseille, 1720, the Russian plague, the Philadelphia yellow fever epidemic in 1793. Then you had the American polio epidemic in 1916, which actually affected FDR. The pandemic Spanish flu, 1918 to 20, that really wiped out a very large population. Then it was not until 1981 that you had the AIDS pandemic, and it's still present. We've not really gotten rid of that. And then you have the H1N1 swine flu pandemic, the Western African Ebola epidemic, 2014 to 16, that we really knew how to attack it, and now pretty much we got it under control. And our worst enemy that we are combating is the COVID-19, and it's still going to be there. So let's look at how we can address some of the clinical problems here. What can we learn from the Spanish flu of 1918? Look at how the health authorities and the community behaved in controlling the Spanish flu. 1918, what can we learn? Look at those masks, the cloth mask. They didn't know much about social distancing, but they wore a mask, there was some isolation, and you will see that all the public places were ordered to be closed. Exactly what we are doing now as of March 18, all the public places were closed. That's the lockdown. We learned this from 1918. So there are lessons to be learned from the troubles from the past. What do they say? Don't spit. Spitting spreads Spanish influenza.
It was actually sneezing and coughing, and that was not really known at that point. So they said, you know what, don't spit. And that's a good thing to do.
Then they closed schools, churches, theaters. They really didn't know what was going to hit them, so they pretty much banned all of the public gathering. And there you see, isolation is remedy for the flu epidemic. Then you had the cases of pneumonia, which was superimposing over the flu. And wear a mask. That's a noble thing to do. And did we really follow that? No, we forgot about it, right? So it took about 100,000 deaths to really understand the utilization of a mask. So if you have an issue that was actually controlled a century ago, just because it's a century old doesn't mean it doesn't work. We could have probably stopped half the spread if we followed the guidelines of 1918. The flu is increasing. If you want to play it safe, look at what they're saying. Keep away from sick people. Very simple, right? Isolate. Use your handkerchief when you cough and sneeze. Of course, we don't use handkerchief at this point. Avoid crowded streets. Wash your hands before eating. Keep your fingers out of your mouth. Because they really didn't know the pathogenesis. So all these 8 techniques really brought the morbidity down. how it should be treated. Okay, go take a rest. This is exactly what we're doing. We're going home, staying, and doing nothing. There's really nothing that we can do. And what did they use for their mask? This was the so-called N95. Before even you knew about N95, they had a special mask that actually was able to provide positive pressure and kept the patients breathing through this little mask, which was fitted very well. And today we call it as a fitted N95. And look at dentistry. Dentistry in 1980, right? We didn't have aerosols then. Everything was belt driven. So dentistry was a safe place to practice, even though you didn't wear gloves, you didn't wear masks. We really didn't have any aerosol to deal with, and dentistry went on as normal. The dental clinics were not shut in 1980. And in the 50s, you started to see the speeds increase, and then you're beginning to see no gloves, right? Till 1950, there were no gloves. People were not wearing masks. They wore street clothes, and they wear a white gown. Why? Because if you had a splatter, you will want to change it. If you had a different color, you wouldn't mind wearing this for a whole day. So this was a means to identify splatter and the influence of debris going over your attire. This is 1973. I showed this video to many of you.
Was performed by
Dr. Linkow performed
surgery
surgery in 1973.
The surgery was done at the 1973 Midwinter Chicago Dental Meeting, where for the first time live surgery was performed in front of a very large audience.
How safe it was. 73. This is in front of a big audience of 2,000 people.
Functioning well and feeling extremely happy.
Right, so he's going to perform 4 surgeries, one after the other.
Right, Ridge. Then we have the first X-ray on that. X-ray on it, on the patient, please. Now this shows you a lot of alveolar bone to the mouth.
Truly the father of modern implantology.
And again, let's hold his tongue.
No
and
glove.
again, an incision is made
right, so
from the retinal of that area.
Of course, you have to manicure yourself well because you're in front of the camera. Right, so this is the incision, and we use high-speed aerosols. Right, so the high-speed bovine hand feed. Reduction of the ridge. Right, and at that point, we really didn't have any reports. You can see how wet the fingers are with all the blood. Instant paralysis.
It's a single-headed. Setting is on a double-headed blade.
We were doing. They were doing in the 70s.
Take it out. 6.
And
1,
if you
2.
look at the use of
Seconds.
the gloves.
1, 2, 3. Home. Listen. Now this one, I'm still not 100%. Okay, I'll settle for that.
I was not wearing gloves till 1989. Right, it was not a requirement. I went to 2 different dental schools, and gloves was not a requirement. Right, so there was no necessity. Right, I used to remember the hands were bathing in blood, and we didn't know anything about infection control. Right, we took a set of syringes and injected the patient. There used to be 100 syringes in a broth, and again, there was no sign of any kind of transmission at that point, maybe because of ignorance, or maybe we didn't assess the problems. So let's see when gloves really came about. So it was in 1965, the same Ansell company that manufactures your sterile gloves increased the production and came up with the so-called surgical gloves. So it took 100 years before the profession started to realize that they should wear gloves. Joseph Lister emphasized it in 1865. So it took 100 years for the medical profession to realize something like gloves should be worn for surgery to reduce the risk of contamination. Still, it was not very popular. It was not until 1985 when AIDS became rampant, the medical profession said we have to wear gloves. Even in 85, it was not a requirement in dentistry to wear gloves. So it was not until 1992 that OSHA stepped up and said, this is going to be a big problem. We will ensure the safety and and efficacy of our employees. So OSHA was the voice behind all of our employees, and they said we will protect both the operator, patient, and the staff so that we can minimize the risk of the spread of HIV. But to date, thanks to OSHA and our infection control protocol, there's not been a single instance of transmission of HIV from a patient to a dentist or from a dentist to a patient in the dental practice. That says something about who we are and how we practice in our own domain. Right? So if we can do this with AIDS, which is a killer disease, we can certainly beat this COVID. And we want to be able to dispel all the myths so we can prevail. Science can prevail, and our patients can continue the benefits of dentistry that we are promoting. So let's understand about precautions. The OSHA recommendation for infection control, standard precautions is very simple. Wash your hands, PPE when exposure is affected, follow respiratory hygiene, and basically that's standard precaution for examination. Then you have contact precaution. Somebody who's going to be coming into contact with a patient, then you have to have a different type of PPE and infection control process. Then we also need to understand what the droplet and airborne precautions are. So knowing this, that there's a contact precaution and a droplet precaution, there's a transmission-based precaution that we should be employing. I want to ask you a question. Can we launch the first poll? All right, so what is COVID? What type of infection is that? Basically, the responses are fluids, contact, droplet, and airborne particles. So the right response is droplet. Okay, so let's see what we mean by droplets. So standard precautions are pathogens transmitted by respiratory droplets generated by patients who sneeze, cough, or talk. So basically, droplet precautions are to be taken when you know that the pathogens are transmitted by droplets, when they cough or sneeze, and the particle size are generally greater than 10 microns. This is important to understand because this sets the stage for the whole presentation. Okay, the pathogen, whereas airborne precautions are to be taken when you are suspecting the pathogens to be transmitted by the airborne route, which means just particles floating in the air. So some of the diseases are chickenpox, measles, tuberculosis, herpes zoster, and the particle size there are less than 5 microns. So when you suspect an airborne epidemic, then you're looking at a hospital setting. So you're looking at an airborne infection isolation room. So when somebody has TB, you're putting in patient into a negative pressure. Why? Because it's airborne. It's a hospital setting. You will not be seeing the patient as an outpatient setting. You will allow limited healthcare personnel only. You need a closely fitted NIOSH approved N95 or a higher level respirator. So now you're looking at a hospital-based model versus an ambulatory model. Okay, so this is typically how an airborne disease is transmitted, right? So when you cough or sneeze, the particles, which are about 10 microns, could get transmitted through this route, and they get lodged into the respiratory mucosa. Why is that important? Because it has an affinity to the respiratory epithelium. It cannot sit on keratinized tissue. So if I cough and there is going to be some virus particles on my hand and somebody else touches my hand, you're not going to get COVID just by touching because that's not the mode of transmission, right? So shaking hands, why do you avoid shaking hands? Because you can carry that virus, and then when you go to rub your eyes, it would go into the mucous membrane of the nose or the mouth or the eyes, but eyes is not respiratory mucosa. How can rubbing the eye cause COVID? The problem is when you rub the eyes, that virus particle can go into the nasolacrimal duct that drains into the inferior meatus. So this is how you get transmission of COVID through all these indirect routes. And that's why you say social distancing. You don't want to shake hands. And I would say, don't even do the elbow. Elbow is probably very bad, because when you sneeze, what are you asking the patients to do? You're asking the patients to sneeze with their elbow covered. So you're going to be laden with a lot of particles. And now if you elbow, you're creating more complications. So better to stay away in terms of social distancing. Then when the patient sneezes, what really happens at the virus level?
This is SARS-CoV-2. It belongs to the family of coronaviruses named for the crown-like spikes on their surfaces. SARS-CoV-2 can cause COVID-19, a contagious viral infection that attacks primarily your throat and lungs. What actually happens in your body when you contract the coronavirus? What exactly causes your body to develop pneumonia? And how would a vaccine work? The coronavirus must infect living cells in order to reproduce. Let's have a closer look. Inside the virus, genetic material contains the information to make more copies of itself. A protein shell provides a hard protective enclosure for the genetic material as the virus travels between the people it infects. An outer envelope allows the virus to infect cells by merging with the cell's outer membrane. Projecting from the envelope are spikes of protein molecules. Both a typical influenza virus and the new coronavirus use their spikes like a key to get inside a cell in your body, where it takes over the cell's internal machinery, repurposing it to build the components of new viruses. When an infected person talks, coughs, or sneezes, droplets carrying the virus may land in your mouth or nose and then move into your lungs. Once inside your body, the virus comes in contact with cells in your throat, nose, or lungs. One spike on the virus inserts into a receptor molecule on your healthy cell membrane like a key in a lock. This action allows the virus to get inside your cell. A typical flu virus would travel inside a sac made from your cell membrane to your cell's nucleus that houses all its genetic material. The coronavirus, on the other hand, doesn't need to enter the host cell nucleus. It can directly access parts of the host cell called ribosomes. Ribosomes use genetic information from the virus to make viral proteins, such as the spikes on the virus's surface. A packaging structure in your cell then carries the spikes in vesicles which merge with your cell's outer layer, the cell membrane. All the parts needed to create a new virus gather just beneath your cell's membrane. Then, a new virus begins to bud off from the cell's membrane. Now, with the virus spreading in your body, how can you develop pneumonia symptoms? For this, we'll have to look into your lungs. Each lung has separate sections called lobes. Normally, as you breathe, air moves freely through your trachea or windpipe, then through large tubes called bronchi, through smaller tubes called bronchioles, and finally into tiny sacs called alveoli. Your airways and alveoli are flexible and springy. When you breathe in, each air sac inflates like a small balloon. And when you exhale, the sacs deflate. Small blood vessels called capillaries surround your alveoli. Oxygen from the air you breathe passes into your capillaries, and then carbon dioxide from your body passes out of your capillaries into your alveoli so that your lungs can get rid of it when you exhale. Your airways catch most germs in the mucus that lines your trachea, bronchi, and bronchioles. In a healthy body, hair-like cilia lining the tubes constantly push the mucus and germs out of your airways, where you might expel them by coughing. Normally, cells of your immune system attack viruses and germs that make it past your mucus and cilia and enter your alveoli. However, if your immune system is weakened, like in the case of a coronavirus infection, the virus can overwhelm your immune cells, and your bronchioles and alveoli become inflamed as your immune system attacks the multiplying viruses. The inflammation can cause your alveoli to fill with fluid, making it difficult for your body to get the oxygen it needs. You could develop lobar pneumonia, where one lobe of your lungs is affected, or you could have bronchopneumonia that affects many areas of both lungs. Pneumonia may cause difficulty breathing, chest pain, coughing, fever and chills, confusion, headache, muscle pain, and fatigue. It can also lead to more serious complications. Respiratory failure occurs when your breathing becomes so difficult that you need a machine called a ventilator to help you breathe. These are the machines that save lives and that medical device companies currently ramp up production for. Whether you would develop these symptoms depends on a lot of factors, such as your age and whether you already have an existing condition. While this all sounds scary, the push to develop a coronavirus vaccine is moving at high speed. Studies of other coronaviruses led most researchers to assume that people who have recovered from a SARS-CoV-2 infection could be protected from reinfection for a period of time. But that assumption needs to be backed by empirical evidence, and some studies suggest otherwise. There are several different approaches for a potential vaccine against the coronavirus. The basic idea is that you would get a shot that contains faint versions of the virus.
So basically, we are trying to develop the vaccine, and we are too optimistic to say we're going to try and get it out by 2020. So a typical vaccine takes about 4 to 5 years to develop. And we are being optimistic in saying we are going to get it out in a year. So we certainly would welcome the advent of a vaccine. So when you talk about droplet nuclei and droplets are generally greater than or equal to 5 microns, and the droplet nuclei is less than or equal to 5 microns.
And the difference between droplets and droplet nuclei. Droplets are usually considered to be greater than 5 micrometers in size, whereas droplet nuclei, which are particles that arise from the desiccation of the suspended droplets, can be smaller than 5 micrometers in size, which is called the respirable range. And those have been associated with airborne transmission. Organisms transmitted by the droplet route don't remain infective over long distances and therefore don't require things like negative air pressure rooms. But those that can be transmitted through aerosolization of droplet nuclei are a different story. So just to recap, with droplet precautions, some of the strategies would be to place the patient in a single room. The patient wears a mask anytime they're outside of that room, and providers wear a mask upon entering the room. So typically with standard precautions, you would put a mask on, right before patient treatment, and probably with the patient right there. In this case, you'd put it on before you walk in the room. And again, no special air handling like negative air pressure is required, and respirators are not required. And this would be for very simple things like the patient has symptoms, you suspect they may be ill, you put a mask on them, you talk about, why you're going to defer treatment and then send them home. This is not for providing care that would use, say, a handpiece or anything else that might generate aerosols like an air and water syringe. And finally, we get to airborne transmission. This is the highest tier on transmission-based precautions. Dissemination of either airborne droplet nuclei or small particles that are in the respirable size range, that's under 5 micrometers, and they contain infectious agents that may remain infective over time and distance, such as spores of Aspergillus and Mycobacterium tuberculosis. Examples of agents that are also transmitted primarily by the airborne route include tuberculosis, the rubeola virus that causes measles, and the varicella zoster virus that causes chickenpox. This is not an area that we've spent a lot of time on in dentistry, so I think that it can cause a lot of confusion. And one of the things that really helped me understand why we kind of straddle the line between droplet precautions and airborne precautions when we talk about COVID-19 is this concept of the airborne transmission falling into 3 different classifications of transmission route. The first being obligate, where under natural conditions, disease occurs following transmission of the agent only through inhalation of small particle aerosols, such as tuberculosis, a true aerosol transmitted disease not transmitted by other means, such as contact with contaminated surfaces. And then there's the second group, which are natural infections that result from transmission through multiple routes, but small particle aerosols are the predominant route, such as measles and varicella. They are really considered airborne transmission diseases, but they could also be transmitted through droplet. And then finally, there's opportunistic agents that naturally cause disease through other routes. So they're not primarily airborne, but under special circumstances, they may be transmitted via fine particle aerosols. And this is where we find SARS and presumably COVID-19. We'll know more, of course, as time goes on and research is done. Also, other respiratory illnesses such as influenza and also norovirus and smallpox are all considered opportunistic agents when it comes to airborne transmission. Patients with confirmed or persons under investigation for suspected infection with COVID-19, the recommendations are that you would treat these patients under airborne precautions. And that means the use of respirators, the use of airborne infection isolation rooms, and other additional administrative and work practice controls, which I'll talk about a little bit on the next slide. So in dentistry, that really means if you have a patient that you've screened and they say, you know, I've been told I have COVID-19, or I'm being investigated for a suspected infection, perhaps they're in quarantine because they've had an exposure, those patients should not be seen in most dental settings because we can't provide these types of airborne precautions, and they could be referred to an appropriate facility. One of the main components of airborne precautions is the use of isolation rooms, and these airborne infection isolation rooms, or called AIIRs, have very specific requirements. It's not just taking a private room and changing the air exchange and considering it a isolation room. It has to have a specific number of air exchanges. For new construction, that would be 12 air exchanges per hour. It's allowed for existing AIIRs to maintain 6 air exchanges per hour. There has to be a pressure differential between the room and the adjacent areas. So the isolation room would have negative air pressure, which is achieved by having only air exhaust from that room, and the only air intake would be the small amount that comes in under the door. There also has to be monitoring of that pressure differential. It has to be at a certain level in order to truly be considered negative air pressure. Then that air that does exhaust can't be recirculated within the building and potentially contaminate other rooms. It has to exhaust to either the outdoors, or it can be exhausted through a HEPA filter. Material for walls and floors has to be able to be cleaned and disinfected. And there have to be signs on the room that restrict entry so people know that they can't walk into that room without proper PPE.
These are the basic posters that are there available. You can use them for a quick reference. A contact precaution is when you would expect to touch the patient. All right, so we don't really touch patients or examine them like physicians. So that would be specific to an examination process that is going to be specific for a physician's office setting. Droplet precaution is what you and I worry about. Okay, these are droplet precautions that we need to take. Clean your hands, wash your hands, use hand sanitizer before and after entering the room. Then make sure that you have your eyes, nose, mouth covered before entering the room, and remove face protection. They will talk about how to wear these PPEs. And airborne precautions, again, is what is getting confused with droplet precautions. If you think you're going to make your office that is going to be complying with an airborne precautions, you may have to pretty much tear your entire office down and start from scratch. There's no way you can retrofit your existing office to be an OSHA standard requirement for airborne precautions. And I'm sure Mr. Lees is going to cover that aspect of it. So modes of transmission of COVID are pretty much droplet transmission versus airborne transmission. So this is typically how it's transmitted. Okay. So modes of transmission, this is the hyperlink. We talk about how the droplet transmission occurs, and this is all from the World Health Organization. So I'll be happy to provide you with the link and implications of the air sampling and what they have done. So conclusions, okay, based on the available evidence, for people who are active COVID-19 patients, follow the airborne precautions, which means they are not going to get elective procedures in your practices. And they need to be referred to a special facility that is equipped to handle such patients. Okay, so, and then it talks about PPE. All right, current WHO recommendations emphasize the importance of rational and appropriate use of PPE, not only masks, but also proper hygiene procedures. And they don't really specify the type of mask because we're going to be talking about that in the subsequent slide. How can I protect patients during these pandemic times? Okay, so let's see how we can get this to work. So limit aerosol production, take the temperature of staff and the patients and yourself, have a good health history questionnaire. So I will be giving you handouts for these health history questionnaire and also for the consent for treatment. Physical distancing, adequate time turnover for patients. Mind you, it's going to take a while before you start seeing the next patient. So if you have 10 operatories, no problem. You can alternate and see as many patients as you want in terms of pacing it. But if you only have 2 operatories, you're pretty much going to have about 2 hours of downtime for an entire day. So factor those in. Then PPE protocols follow, and universal precautions should be standard. So when we look at all of
Dr.
these, yes?
Dr. Hi, it's Varun. Sorry to
Yes, Varun.
interrupt. So a question which is on everyone's mind, can I ask that now?
Yes, please. Of course, this is going to be interactive. Absolutely.
Yeah, so all of the precautions, the airborne precautions which you were talking about, which people are trying to implement, however unsuccessfully, they're trying to implement because there's the assumption that we have asymptomatic carriers who are spreading the disease even while they're talking. They may not be coughing, but they may be talking and breathing, and therefore they could be spreading the virus. So the question on everyone's mind is, how do we differentiate? How do we know that the person coming in doesn't have the virus? Especially, let's say in India, it's not so easy to get the tests. They're making things very difficult to get diagnostic tests to actually evaluate. And even we know that the tests are not really very conclusive. There are false positives, there's false negatives. So this is the reason why everyone's trying to implement some version of airborne precaution, is just basically out of fear. So how do you address that question of the asymptomatic carriers?
So it's always the fear of the unknown, right? So you're pretending that everybody has active COVID, and if you want to get into that mode, then you pretty much will not have many patients to treat, because the procedure tells you don't do anything other than emergency procedures. So you can stop your practice, right? So you have to be sensible enough to maybe spend an extra 25 minutes going through some questionnaire. Where have you traveled? And you have a detailed questionnaire. When the patient is not showing signs of any kind of increased temperature, you have to take the patient's word for it. And even with your limited droplet protocol, you're still safe, right? The fact that you are covering, and that's what I'm going to get to it. The fact that you are looking at a patient who is highly infective is going to have a droplet protocol follow. Okay, so the aerosol is only going to happen when you expect the patient to continuously cough and sneeze, because anytime the patient talks, the saliva is going to come out, and there is a distance to which it will travel and it will drop. By talking, you're not going to put particles of the virus in the air. That's a myth. When you cough, you're coughing the particles, which is going to have a certain limit in terms of the travel. It may go at the rate of about 10 meters a second. When you sneeze, it might go 50 meters a second, right? How many healthy patients have you seen sneeze and all you do is just cover your elbow? Nothing has changed, right? For the past 100 odd years that dentistry has been in practice in India, this has never been a problem. So when you look at who is going to be affected, who is transmitting the disease, you are thinking that they are going to have the disease. So all you can do is follow universal precautions. Universal precaution is more than adequate to protect you from an active COVID patient. Unless and until you're going to do endotracheal intubation, you're going to do something invasive, that's when you need to have these respirators, because there you're expecting airborne particles to come out. So we will talk about this. Again, you're going to have Mr. Jim Lees clarify all of this. So what do the ENT surgeons and the people in the emergency room have? They have nothing They have nothing close to what we have in our clinics. We have HVAC, right? They don't have suction in the ER. They don't have this high volume evacuation equipment. They don't have the kind of retractors. They don't have rubber dams. They don't have much of what we are doing to protect our patients available there. So those people need these kinds of protocols to qualify it as airborne, because now you're ventilating a patient. So the chance of an airborne becoming dominant is higher. Is that making sense, Varun?
Yes, that makes a lot of sense, and I think the question really is then becomes, if we are aerosolizing the saliva of,
yes,
I'm
yes,
sure
yes.
that's coming.
But as of now, a patient walks in, what are you going to do? You're triaging the patient, right? You're going to probably have an extra person who is going to get a complete history of the patient and tell the patient, listen, you got to be truthful. Just like the way we were scared when the HIV patients came into our practice, we were freaking out, right? We thought, we're also going to get AIDS. And what did people do? People are wearing 2 gloves and 3 gloves, and they thought wearing 2 gloves is better than having 1. And the patient said, the healthcare worker said, maybe we should have 3 gloves on, because that's even better. But what does the research show? So let's not panic and do things which are going to be counterproductive. Let's understand the etiopathogenesis. Let's understand the science, so we can attack this sensibly and not senselessly. So we will talk about the aerosolization, and we will talk about the control in a few minutes. But a very good point, and I'll keep bringing it up over and over again. Avoid treating active COVID patients suspected. Of course, it's easier to say, but how are you going to diagnose, and how are you going to prevent this from spreading? So this is typically how an Ebola management should take place, right? Now, do you expect your dental practice to become like this? I think it would be meaningless to have this kind of a bodysuit and be practical. This is one patient that's being treated. Dental patients are 15, 16 a day. Can you imagine tearing this down and putting it back in? And if you are taking a photo of just for that one patient, it looks nice on Facebook, but it's not a practical thing to do for every patient, right? This is when common sense should prevail over this kind of arbitrary practices. So this, of course, is important because Ebola is a lethal disease, right? You know the reason it can kill you. It's a hemorrhagic condition. So of course, you're going to take extra precaution, and you're not doing dentistry on these patients, okay? So the attire and the rooms are completely different than what we would expect a COVID patient to go through. So we think COVID is now going to be so severe like Ebola, we have to wear a bodysuit. Not a single protocol calls for a bodysuit anywhere in the world, okay? This is what was the initial management. We didn't know how to protect ourselves. So we were using, or rather the people from Wuhan were using these double filtered masks. They were fumigating themselves, and they wore this bodysuit because they didn't know what was hitting them. So you went in with big guns to kind of protect yourself from this little virus, okay? So initial management, if you saw pictures from Wuhan, they were all like this. Now you go to an ER and see what is going on. This is typically how you're seeing the ERs in the United States. You go to Columbia Hospital, you go to NYU, they are wearing this. Exactly what you see is what our physicians are wearing currently, and this has been updated as of 3 days ago. They're having this protocol to don themselves. So if the physicians are going in at this level, okay, so think about what we should be doing. Of course, we need to be cautious too, but let's not drive ourselves crazy. The fact that you have a face mask is going to give you some level of protection up to 5 microns. The face shield is going to protect you from splatter. You're going to have a full cover. Now, do I need to have a head cover? We'll talk about that. Should I wear a shoe cover? Should I wear a disposable gown for every procedure? We will discuss all of this. Okay, so you can see how the evolution of PPE has changed within the medical profession. Now you don't see people wearing these N95s with the respirators walking around from a hospital. And you've seen all of the video footage that's coming out of hospital. You rarely find somebody with the respirator in an active setting. So now let's look at this types of masks, and I'm going to show you the different types in a minute. And I want to thank Dr. Vadivel Kumar, my co-director, who was bold enough to come out and tell it as it is. Okay, so he was given this respirator and he was given this bodysuit, and I'm going to play this video. It may look a little facetious, but so he's been wearing this for about 3-4 hours, I believe. Right, so now can you imagine, after a patient, if you were to do this, how are you going to disinfect that respirator? Are we going to have 8 respirators in our office? And it takes about 10-15 minutes to clean all of that. And who's going to hold it? And how are you going to touch it? We have no protocols for that, right? How are you going to sterilize that? And now you're going to do an implant surgery, right? So now asepsis is going to be thrown out of the window over this respirator. And how do you can't put this in an autoclave, right? There's a protocol. Should I put it in Clorox? Should I put it in chlorhexidine? Should I do a hypochlorous solution? So this is where madness starts to set in. We really don't have protocols. We know what it is, but then we cannot walk this to the very end and complete a procedure like a surgical procedure. Look at the oral surgeons, look at ourselves. When you're doing a sinus graft, can you imagine wearing this with an aseptic? It's supposed to be aseptic. Now you're wearing a device which is totally not sterilized, okay? And now you're going to go and operate and open somebody's sinuses, right? So let's be realistic in how this is going to be playing out and see what happens here, right? So now he's double gloving. So there he is. So after, so far so good. Now what's prompting him to come out? Right, so this is a body coat, right? Can you, that's like 2 cups of sweat that just came out of his body from this body coat. Okay, so if we take this route, dentistry will be doomed, and you're justified in creating the allowance. So let's not get into that aspect of a procedure that's going to be draconian. Okay, so when we look at what constitutes evidence, right? So when we talk about comparison of surgical masks, KN95, 95, and respirators, there's got to be a gold standard, right? So Varun, you rightly said, when am I going to use this? So the gold standard of a research, what do you think it is? Varun, you have the microphone. What, in the terms of hierarchy, what is the number 1 in terms of evidence?
Probably the surgical mask, the simple surgical mask.
In terms of evidence, I'm talking about the type of research. What's written here, right?
Meta-analysis and systematic reviews, yeah.
Systematic review, and the second level is randomized clinical trial. You are a double postgraduate, so you know what it is to go with the systematic review. And then the real thing is, let's go and see what the systematic review says. Okay. So you have this handout here, which I'm going to show you what it is. So here is the meta-analysis and systematic review. I'm going to double click that. And let's open up and see. All of you should be able to see it. It is the effectiveness of N95 respirators versus surgical masks in protecting healthcare workers from acute respiratory infection, a systematic review, and a meta-analysis. Okay, so of course we talk about the interpretation. Although N95 respirators appear to have a protective advantage over surgical masks in a laboratory setting, our meta-analysis showed that there is insufficient data to determine definitively whether N95 respirators are superior to surgical masks in protecting healthcare workers against transmissible acute respiratory infections in clinical settings. Okay, so this is one systematic review. Let's look at the second systematic review, latest meta-analysis. So this is as recent as 2020 from this Chinese group who were pretty much were living and breathing N95 masks. Okay, so here we have effectiveness of N95 versus surgical mask against influenza, a systematic review and meta-analysis. Conclusion: the use of N95 respirators compared with surgical masks is not associated with a lower risk of laboratory confirmed influenza. It suggests that N respirators should not be recommended for general public and non-high risk medical staff, those are not in close contact with influenza patients or suspected influenza patients. Okay, so I have the literature replete with this. And then the one that really shook the community was this study here, right? This study, which was by the Clinical Infectious Disease, 2010. Okay, this is an abstract that you will see. Again, this is all available for you to review. Okay, though it cannot be denied that N95 used properly will filter out small particles than surgical masks, it is highly doubtful that N95 are cost effective or worth the effort of routine care of patients with pandemic H1N1. Exceptions could be made for high risk groups such as pregnant workers. For others, the use of N95 for what is almost a minor illness seems unreasonable. So I rest my case. I have done a lot of literature research. In fact, if you look at my review of literature here, right, so this is my initial review. Surgical mask versus N95 for preventing influenza. This is the randomized trial that I was talking to you about. So this is now a trial which blew everything out of water. So this was the first randomized trial. Can you imagine doing a randomized control trial with two types of masks? If one was inferior, they would not have subjected the workers for that. So look at the results. Conclusion: this was done in Ontario. Among nurses in Ontario tertiary care hospitals, the use of a surgical mask compared with N95 respirator resulted in non-inferior rates of laboratory confirmed influenza, right? So, I mean, I've got all these articles that I'll be happy to share with you, and these are over 40 articles that I've collected, okay? And the only one which really says that there's something to do with N95 is a Chinese article when they were trying to show that N95 was slightly better than the surgical masks. All right, so this is the reason. So when you look at what Voltaire said, the perfect is the enemy of good. How perfect do you want to be? All right, are we looking at the gold standard, the ultimate imperfection? Then that's going to be the cause of our demise. So with that said, I would like to introduce our guest speaker, Jim Lees. He's the owner and president of AK Medical Services. And I spoke to you earlier about the difference between CDC and OSHA. CDC only gives guidelines. CDC is not going to come and knock on your doors and say, are you following the protocols? OSHA is the one which is going to come to our offices and knock on our door. For all the US participants, this is going to be very meaningful. And this again will translate into other countries because OSHA is being held at the highest standards in terms of compliance for protecting our workers. So he was on the ground floor of the HIPAA legislation, right, in 2003. And he's also written several chapters. And he helped create the OSHA document way back in 1992. Jim, over to you.
Hello. Can you hear me?
We can hear you, kind of, yes.
Okay, you can hear me and see me? Yes. Good? Okay. Ready, set, go. Well, thank you, doctor, for inviting me, and thank you for clarifying that N95 surgical mask thing, because that's taken up a great deal of my life. By trade, I am a federal OSHA litigation attorney, and I have been protecting dental doctors.
Jim, I know you speak a mile a minute. We have participants from 35 countries. English is not the first language, so go a little slow.
Not a problem. So like I said, I've been litigating for the dental community for 30 plus years. I was there on the ground floor. I've been doing this for over 30 some odd years. Have been protecting the dental community from one form of government and one form of government only, and that's OSHA. I have written a binder specifically here. It's for the bloodborne pathogen standard and for the hazard communication standard, as well as the most important thing is the personal protective equipment standard. So what's going on out there right now in the dental community all across the world, it doesn't matter where you are, it seems like there's a tremendous amount of disinformation, okay? Like the doctor said, you can have information from the CDC, you can have information from the ADA, the AMA, all these other regulatory bodies. The only thing they can do is, in the United States, for us, is make recommendations. Okay, there's only one regulatory body in the United States that can enforce safety in the workplace, and that's OSHA. So the way I protect you is I've made relationships through all 10 of the OSHA regions over the last 30 years. I know what they're looking for. I know what they're expecting of you. Has this pandemic been a bit of a struggle? It's been a bear, okay, because it's unprecedented. So there really is no precedent that we can go forward with. But through perseverance, I tackled this by the horns, and I actually was able to secure a document from the federal government, from OSHA, regarding this whole respiratory protection equipment standard, okay? To get the government to put something in writing is enormously difficult, because what was happening is all these regulatory agents, I have letters from governors saying that the respiratory protection standard that we have in the United States here, 1910-134, you must do a fit test, you must do a qualified fit test, a qualitative fit test, you must have a respiratory protection program in place, you must medically evaluate all your employees to see if they are good to wear the respirator, the N95, and guess what? None of that's true. Okay, and I have it from governors and dental hygiene associations all across the United States saying, well, no, they have to. My argument was to the federal government, very simple. I understand the respiratory protection standard, 1910-134, blah, blah, blah. It does not apply to dentistry. Okay, if you're in any other, because I've been putting in workplaces for years, it does not apply to dentistry. There is no direct correlation or direct translation. It just doesn't work. So I went meeting after meeting, Zoom meeting after Skype meeting after in-person meeting, and I actually finally got them agreed that if someone is going to provide an N95 respirator to their employees, that's wonderful. That's strictly voluntary. Okay, and when it becomes voluntary, as the email and the document from OSHA says, all you have to do as a dental practitioner is have something very simple in the United States. It's called Appendix D of the bloodborne pathogen standard, and you would just explain that to them, the manufacturer's recommendations, and they would wear the mask accordingly. It's not mandatory, it's completely voluntary. Now, it's a tough battle to fight, I know, because you have a lot of people out there putting a lot of pressure on you, showing you all this stuff from the respiratory protection standard saying it is mandatory. Guess what? It's not. And as the doctor so clearly proved, that a level 3 mask with a full face shield is good to go. And that's all OSHA will be expecting of you. Okay? So that's a good,
I sorry to interrupt. I just, because here we are practicing in a litigious society. All right, what are my chances if my employee says, you know what, I heard that you have to give me a N95 mask, otherwise I'll not come to work. Is there any basis for that?
Absolutely. There's enough. You yourself provided 3 scientific studies, and I have a couple as well that I use, because when I have a client of mine, I found the best way to arm them is with information. What's happened is when people get left in the dark and they don't have information and there's no communication, that's when employees get jittery. That's when doctors get jittery. That's when we all get nervous. my job is to make sure all that gray area is cleared up. I actually have Zoom meetings with the employees if they want. I talk to them one-on-one. I text, I Skype, I call them after work. I present it in a very concise, clear manner to allay their fears, to make them feel comfortable to going back into the dental environment. And it's tough right out there because, like I said, it's scary. There is no precedent for this stuff. So it is a bit of a battle, but I have the legal documentation for my clients that there is no respiratory protection standard required, no medical evaluation, and no or qualitative fit test. So that's a very good thing. The very next question I'm asked about, and it happens all the time, is about what do we wear? What clothing do I need to provide my employees for them to be safe? Well, traditionally in the United States, since the bloodborne pathogen standard since 1991, it was a little dirty, unknown secret, I guess, if you will, that employees would wear their scrubs to work, they do their job, and they would go take those scrubs home and launder them. And probably about 85% of the practices that I go to, it's still done commonly in America. Okay, guess what? That can't be done anymore. All right, an employee has to come to work in some version of street clothes. It could be just, shirt, pants, whatever the case may be. And they also have to, if they want to come to work in scrubs, that's fine. But it's now going to be incumbent upon the employer, you, the doctor, to provide some type of PPE to make them safe, whether it's a full surgical disposable gown or whether it's a full-length lab coat. Doesn't make a difference to me. Okay. Now, what about laundering these things? What about changing them things? I have ad infinitum, ad nauseum questions from dental hygienists saying that, well, I want an N95 and I want to change my respirator after every patient. I want to change my disposable gown after every patient. Well, if that's the case, I don't know how you're going to keep the doors open. And that's not the law. Clearly, that's not the law. I could quote the bloodborne pathogen standard. I could quote the personal protective equipment standard. I could quote OSHA right from the COVID-19 release form that I had to create. Okay. You change your disposable gowns only when they become overtly contaminated, ripped, torn, or not, they don't function. They can be worn throughout the day. Same thing with the lab coats. If you're providing them, they can be worn throughout the day unless they become soiled, ripped, or torn. The integrity doesn't work. You have to launder them. Yep. Can they take them home? Nope, they can't. You either have to have a service, or you have to have something on site, or you actually have to have the employer, clean those lab jackets. So those are the two things now that regarding PPE. I also get a lot of questions about head coverings and foot coverings. It's completely up to the discretion of the healthcare professional. Okay. So whether they're good or not, I don't, if you have them, you want to provide them for a comfort level, that's perfectly fine. You can do that. Again, the most are all single-use disposable. Throw them out at the end of the day. Okay. So that's an issue that we can put to bed. Lunchrooms. Doctors are asking me, how do my employees eat? I'm like, well, you can't eat through a mask. I'm pretty sure that can't happen. Lunchrooms in many offices, no matter where you are in the world, they're small places. It's impossible to socially distance. Some of the options that have been presented to me, which make complete sense, is to stagger lunches. Okay, if you can put people 6 feet apart, that's fine. Some people are going out, they have the option to go out to their vehicles, their personal vehicles, they're eating in their cars. You can't eat at the front desk, you can't eat at the operatories, that's old bloodborne stuff, that can't be done. So that's a bit of a tricky issue, is how to stagger lunches to make everybody feel comfortable, okay? Now, one of the other things that has come up a lot is air purification, okay? Well, there is no law, there's no legislation, okay, that says we need to spend $3,000 on an air purification HEPA filter, UV lighting, charcoal filter to attach to our air conditioning system. There isn't anything that says that. Should you get, in my humble opinion, a waiting room air purifier and have something for each operatories? Absolutely. Not only does it recycle and clean the air, I hate to say it's good for patient optics, but it's really good for patient optics, okay? And it's healthy. It's good to clean the air. That's a very important thing as well. Now, what's the likelihood of the OSHA people walking in the United States? Once this is over, I already know right now we have about 2,100 inspectors in the United States through 10 regions. They already have on tap to hire 900 new inspectors. So the question is, are you prepared when they walk through the door? Okay. The ADA produced a nice toolkit, but it was nowhere near what OSHA wanted to see. It just wasn't the document they wanted to see. you need to have something called it's way over there, a COVID-19 transmission prevention program. I have written such a document. It covers everything that the federal government wants to see in your workplace. I have taken this document, I've brought it to OSHA, and they have read it, and they go, Jim, if you can get half of your clients to put this in the workplace, we would be tickled pink. There's going to be no citations issued. There's no secrets here. It's everything the doctor was talking about regarding basic infection control protocol. Are there some other things in there that are a combination of ADA, CDC guidelines? Absolutely. But it's important to have everything in place. It's important to have communication for your employees. And one of the important things that the OSHA people are looking for, I'm just going to tell you what it is. If you have it in your OSHA binder, that's good. It's a standard. It's from April 6, 1994. It's the personal protective equipment standard, where you have to do a hazard assessment of your office, and then you have to train your employees on the appropriate PPE that you're going to use in the workplace. Naturally, of course, that's all part of my binder in my little class. So I don't want to take any much more of your time. This is what I do. This is how I do it. I can keep you very safe in the workplace. I think we've dispelled all the myths about N95 as opposed to level 3s and full face shield. I had an argument with a governor, which is a state that will remain nameless, Connecticut. And what happened was he sent this letter out and says, well, dental office shouldn't be able to practice until they get N95s. Okay, great. 50% of my clients in Connecticut can't get an N95 mask until after December. So how do you do that? And fortunately, he was not in line with the federal government. We have since toned that back down, the rhetoric that was coming out of certain of these offices, and you're going to be safe as long as you follow the protocol the doctor set forth. If you want to hire me to get my OSHA binder, you're more than welcome to do that. I do provide on-site training, Zoom classes, everything that you could possibly need to be safe. Only in the United States, my friends. I'd be happy to visit some of your other countries, but I don't think we can travel very far these days. So again, my name is Jim Leese. The name of my company is AK Medical Services. I know the doctor has my website is www.theoshaman.com. My cell number is 914-497-1353. You can call me. I don't even, if you're not necessarily becoming a customer, and if you have problems in the office, and if you're just trying to get through it, I'll answer your questions. Okay, I've been doing this long enough now. I don't need you to sign up. If you need the help getting compliant, okay, I will give you certainly some information just to try to answer any difficult questions for you. And that's because the doctor can vouch for me, and he brought me on to talk to all you fine folks.
Fantastic, Jim. Thank you so much. You're very kind of you to offer those services, and I do
Not a problem.
have binders, and you stand by it. So if an OSHA officer comes in, I guess who to call. And
right, that's exactly it. If you should ever get an OSHA inspection, an inspector at your door, part of my program is I'm there at no additional charge to protect you from the federal government. I handle all the needle sticks. I handle OSHA inspections. I write anything that you need to have written. I handle the whole thing. It's a pretty neat little package that only taken me 30 years to create, but it's good to go.
Great. And your advice to them in the event somebody knocks on the door, you let them in?
If someone knocks on the door, an OSHA person knocks on the door, you have the right to provide them reasonable access, which is what? 15 days, okay? You have the right to practice your dentistry. You have the right to ensure privacy as well. That's just your first and foremost given responsibility is to practice dentistry and provide healthcare to your patients. While the OSHA stuff is important, you have the right to provide them reasonable access, which is, of course, on page 10 of the OSHA Act from 1970, reasonable access, and that's where I get involved. You call me, I handle the whole thing, and it goes pretty smoothly because, truth be told, is the government doesn't want to do battle with the federal OSHA litigation attorney. There's so many other people out there that are non-compliant. They're just going down the street. In fact, I've developed such a reputation. I just send them the information. This is what we're doing. This is what we have. Oh, Jim Leese, AK Medical. Thank you. Have a nice day. And that's kind of nice. That's a pretty cool thing I've created after all these years. All right, guys.
Super, Jim. Thank you for coming on board. Appreciate your advice. And of course, if you need any assistance, you can reach out to me or reach out to Jim directly. Thanks.
Absolutely.
Again. Wonderful.
All right.
Great
Thank
advice.
you. I have to take off. I got another meeting I'm already late for.
So long. Yes. Wonderful.
Thank you.
Okay. All right. So you can see that it's not the standard of care for dental offices. It is superfluous for droplet nuclei having N95. In fact, I ordered like
10 boxes of N95 and I gave away 8 of those boxes. I've given it to my staff. They are at liberty to use them. I personally use a surgical mask and something like this. Okay, so this is all I'm using in my current practice with a gown as needed for my implant surgeries. And we'll talk about generation of droplet nuclei and how to control that. But when you look at these kinds of masks, you have different types of, this is a N95, right? So you can see how this is really not fitted that well. So don't buy spurious stuff. It should either be from 3M, right? You can see that it's either from 3M, or when you get something like this, what does it say? When you read a close-up of this, it says, it may cause death. Okay, this is what it says on the mask. All right, it says, warning, misuse may result in sickness or death. For proper use, see box or call towel. So you really need to have training for these masks to know how they fit against your face. And then if you have a beard, forget it. You're never going to get it fixed. Many of our friends from the Middle East have thick beards. You just cannot fit them properly. So what do? The virus is non-discriminatory. So when there's a shortage of N95, what did the government say? Use the regular mask, which means, does the virus have so much brain that will say, I now have to be in hiatus. Let them all wear the N95 and then I'm going to attack. Things like this don't happen, right? So you have to have some kind of common sense in trying to get this usable. And I've seen many of them are wearing it for a whole day. I'm very proud of it. Well, power be to you. I'm telling you exactly the way I practice. And if this is not good enough, I don't know what else can protect us from this invisible enemy. This is an ER physician. She came as an emergency to my practice, and listen to what she has to say.
Hi, Dr. Sethi. Thank you for coming. I know you're here for an emergency. So tell us what exactly is going on. You're one of the frontliners. You've been in the ER. You're also in emergency care. So tell us the real story.
So I feel like COVID is just a worst case of the flu. It's unfortunate that we don't have a vaccine right now. Most of the people who are actually dying from this are due to the fact that they have a lot of comorbidities, whether it's diabetes, hypertension, kidney disease. There's a lot of cases of deaths just because of that. And if you look at the number in terms of pediatrics and adult population, it's mainly the adult population and elderly that are that have a decline in immune disease, in their immunity in general. So,
where do you see this go? I mean, if you think it's blown out of proportion, what is the next step?
I think we should just all take precautions. Obviously, hygiene is a really important factor. The social distancing should be there. Wear your masks. Do the sanitizing as much as you can. I don't think.
What about the PPE?
That's not a bad idea. That's also not bad. I don't think it's. It should be used in hospital settings and a lot of urgent care.
What about a dental practice like this? Do you think we need to have N95 and cover your whole head and be like a bodysuit?
No.
Right? You don't think it's an overkill?
No, I don't think it's something that's really you're gonna have to have all this gear on you constantly in a dental practice. No, I would say just be cautious and make sure whoever's coming in, you check their temperature. Do the masks, make sure you're asking them how they're feeling.
Right.
They don't have any of the symptoms of shortness of breath, cough, chest pressure. There are GI symptoms also related with this. So those are the big things that you want to do.
So in terms of being contagious and the aerosols, do you think there's a value or merit to what we are trying to protect ourselves?
There is some value. I wouldn't say that it is, you should take your typical precautious measures. That's
the universal precautions.
Universal precautious measures that you want to do. I would not go to extra lengths,
of trying to get a full seal and fitted N95 and all that is.
No, I don't think that's necessary at all.
Even you guys don't wear that.
Honestly, I've been yelled at. So I was on the COVID unit and I was told do this, do that. But
so you were right there with all the patients who are dying in front of you. And,
and majority of them they're very sick. If you look at even the cause of deaths on a lot of the cases that are being reported, this is just probably a trigger to whatever's already developed with their bodies. It's just like having a really bad case of the flu and then ending up with pneumonia, and that's ends up transcending your entire body downhill.
So personal hygiene, wash between patients.
Exactly, that's it.
Antiseptics.
And if you work in a healthcare setting, just make sure you shower before coming in and shower when you get home. That's it. And change your clothes and put them in the laundry. That's it. Very typical.
Very good. So you've heard it from Dr. SmileUSA, one of our frontliners and a favorite patient of ours. Thank you so much.
Thank you.
Right. She's been with the COVID unit, right? So let's see how to put on our basic PPE. Okay, it's a small video which I want you to know.
How to safely put on personal protective equipment, or more commonly called PPE. We will demonstrate one way to appropriately put on or don PPE. More than one donning method may be acceptable to your facility. It's important that you receive training, demonstrate competency, and practice your healthcare facility's donning procedure. First, identify and gather the proper PPE to don, including an appropriately fitted isolation gown, a NIOSH-approved N95 filtering facepiece respirator or higher level respiratory protection, or if a respirator is not available, a face mask, a face shield or goggles, and a pair of disposable patient examination gloves. Perform hand hygiene by using alcohol-based hand sanitizer or washing your hands with soap and water for at least 20 seconds. Put on the isolation gown. Tie all ties or snap all snaps. You may need assistance from another healthcare provider. Put on the N95 respirator. When using a respirator with a nose piece, fit it to your nose using both hands. Do not bend or tent the respirator. Extend the respirator under your chin, protecting both your mouth and nose. Pull the top strap over your head, placing it on the crown. Then pull the bottom strap over your head, placing it at the base of your neck. Lastly, perform a user seal check. Do this by using your hands to cover the surface of the respirator and gently exhale, checking that the facepiece bulges slightly. Then, while keeping your hands over the respirator, take in a quick, deep breath, checking that the facepiece collapses slightly. If air escapes through the edges, readjust the fit of your respirator and perform another user seal check. Do this each time you put the respirator on. If a respirator is not available, put on a face mask. Extend the face mask under your chin, protecting both your mouth and nose. If the mask has loops, hook them around your ears. If it has ties, secure them at the base of your neck and crown of your head. Next, put on a face shield or goggles. Once again, perform hand hygiene. Lastly, put on your gloves. Pull the gloves down so that they cover the wrist of the gown. You are now ready to enter the patient's room.
Okay, good question. So you don't want to use both because then you're going to get double vision and you will not be able to perform operative procedures. If you use the goggles, is only there for your eye shield. Okay, so if I have this seal and I don't expect anything to really penetrate because the seal is there all the way across. Okay, so if you feel that you need the goggles, it doesn't hurt. But I wouldn't use the goggles and the shield because that will be an overkill. All right, because be kind to yourself. You could do probably half an hour, but after a while, the 2 layers of this plastic is not going to give you the depth of vision. If you do operative, try doing a DO composite on number 17 or number 15. Okay, so try doing that in indirect vision. When you breathe, it should not fog, and you're trying to have 2 layers, which is going to interfere with your depth of vision and will interfere with your overall visibility. So the less layers you have, the better operative procedures you can perform. Okay, so for me, I have to have loops. So that loop is going to be my primary, and this is going to be my secondary. So if my loops have a side shield, which I'm planning to design, then I would not need this extra layer over my eyes. So use of gowns, it's single gowns or multiple use. How do you know that? So may I get a disposable gown? I just want to demonstrate how you should look at that single use gown. It should be breathable.
Dr. Ryan, before we go to the gowns, a quick question. So some of the people I've spoken to, and including myself, this is my experience. When we're using the N95, previously we used to do dentistry very easily from 9 a.m. to 6 p.m. with not much of a challenge. Now it seems like we can do about 2 or 3 hours of very, very basic dentistry, and then we go back home and we collapse for like 2-3 hours. Is that because of the hypoxia from the N95? Would you think?
Absolutely, because you're breathing in carbon dioxide. Nobody is doing. What I would recommend that you do, and maybe we should publish this, put a pulse oximeter on yourself. Okay, let's do a multi-center trial. Put the N95, do some work, and let the pulse oximeter and have your assistant chalk the actual oxygenation level. I will guarantee you are going to get tired after about 2 hours. Why are we killing ourselves? Right? This dentistry should be a pleasure. We are trying to treat patients. What's happened to all the fun times that we used to have in dentistry? Now we are, getting crippled for lack of knowledge. Our ignorance should not be the cause of our lack of judgment. Okay, so you're right. You're getting tired because of lack of oxygen and the fear. You're not able to produce. There's going to be stress. My overheads are through the roof. If I don't see 8 patients, I can't pay my bills. I can't support my staff. All right, so I'm not running a charity center. Right, so in a hospital and university environment, you see 1 patient for a whole day, you're going to get paid. You and I don't get paid that way. Right, we need to treat patients and treat them in a safe and effective manner. So we just need to look at a production line. So I used to be seeing 12-13 patients. Now my patient load is cut into half. Why? Because now I have to make room for the buffer. So you're right. It not only tires you, it also produces disorientation, and you're going to get sleepless night, which is what I'm getting a lot of complaints about. Right? You're waking up in the middle of the night because of lack of oxygenation. So that would be a good trial for us to kind of look at it, because if we want to excel, we need to be in the forefront fighting this. We cannot play second fiddle to somebody else telling us what to do. We are more intelligent than the average practitioner out there. In fact, if the patient wants to be well protected, the safest place they can come to is a dental practice. If you go to a physician's practice, wearing gloves and mask was not the norm until 3 months ago. Right? They examined you with their bare hands. All right? They looked at your eyes, everything was bare hands. Whereas we always followed universal precautions for decades. So the patient is going to be well protected coming to a dental office than going to a hospital, in my personal opinion. Patients don't want to go to the hospital. They fear once you check in, you're never going to check out. So that's the kind of fear that's roaming around here. So the hospitals are now telling us, unless you are ready to die, don't come in. We just cannot accommodate you. The system is getting overwhelmed. Okay.
So did that answer your question, Varun?
Yeah, thank you for answering that. And a quick segue, since we're still on the topic of masks, reusable respirators. You know, what you've been showing us is a disposable respirator, but the reusable respirators, the ones which look like fancy gas masks.
Yes.
What are your thoughts on them? One of the
that.
concerns we had was the exhalation is not filtered in those gas masks because it's a one-way valve. Exhalation is not filtered, but people have been saying that it's more comfortable. So whenever you can, if you can shed some light on that, please.
Sure. Let me get to the actual image and then we can talk about that, right? Sure. So what would we do about visibly soiled? So what is visible soiling? So if you get a gown, just check and see, put it on yourself and then see if it's breathable. There are layers, there are cheap gowns which are not breathable. So a good way to test it, if it's breathable, is to take some water and then just pour on this. Your hands should not get wet, right? So the hands is not getting wet. I could show you, I've poured some water, my hands are dry, because that's a true water repelling gown, which means the spray will go on, it's not going to soil your inner garment. So once you know it is seeping through after 3 or 4 patients, rip it off and then you should wear a new gown. Okay, so till such time, 1 patient per gown is really not an indication at this time. So this is purely your call. If you find that it is kind of soiled, then you would change this and leave it to your assistants to decide how much of that is going to be affected. So how do you change PPE if you called out of room? Let's say, Varun, you're now going to be doing a crown prep and you're completely focused, and now your assistant comes and says, you know, doc, this all-on-4 prosthesis just needs a quick check. The hygienist has finished seeing the patient. Now they want you to okay this. What would you do? And are you going to take everything out, go to the next patient and see the check? So this is the kind of problem you're going to be seeing over and over again. So we need to be prepared to accommodate these kinds of changes. So when you have your schedules, don't club the surgical schedule with the restorative schedule. Our whole schedule is going to be completely different. And if I don't think there's time to go over that, but if there is interest, on a second webinar, we'll talk about how to be productive in a normal day and how you should be spreading out your patients and how your scheduling coordinator should have the presence of mind to book those appointments so that they know that you cannot be disturbed from that procedure and that they don't have a side book with another non-productive procedure. Okay, so we'll get to that. With face shields, not a requirement to change masks, changing gowns, use the protocol, minimize movement from room to room. That's why you need to change the schedule. And then you need to train the front office now for asepsis and not for production. Because my office manager is a slave driver. She puts patients one after the other because I only practice 10 days a month. So they need to drive me to produce my maximum. But that is stopped. I can't do that anymore, right? So now they have to think about how my schedule is going to be placed for aseptic consideration and not necessarily for production alone. Hair or foot coverings? No reason at all. There is absolutely no sense in having a foot cover unless it's a rainy day and you don't want your floors to be soiled. Then of course you can offer some foot covers, but foot cover is not a requirement at this time. Even the head cap is optional. The virus will not thrive on hair follicles. So how do you take it off?
How to safely take off personal protective equipment, more commonly called PPE. We will demonstrate one way to appropriately take off or doff PPE. More than one doffing method may be acceptable to your facility. It's important that you receive training, demonstrate competency in removing your PPE without contaminating yourself, and practice your healthcare facility's doffing procedure. Remove and discard your gloves. Gloves can be removed using more than one technique. For the glove and glove technique, pinch the outside of the glove near the wrist. Peel downwards, pulling the glove inside out. With your ungloved hand, slide your finger under the wrist of your remaining glove. Again, peel downwards, turning the glove inside out. Discard the gloves. For the beaking method, pinch the outside of the glove near the wrist. Using your finger, Pull the glove inside out and over the fingers and thumb to form a beak. With the beaked hand, pinch the opposite glove at the wrist and pull downwards, turning the glove inside out. With the ungloved hand, pull the beaked glove off, touching only the inside of the glove. Next, remove your gown. Untie all ties or unsnap all snaps. Some gown ties can be broken rather than untied. In that instance, break the ties gently, avoiding a forceful movement. Reach up to the shoulders and carefully pull or roll the gown down and away from the body. Dispose of the used gown. You may now exit the patient's room. Perform hand hygiene by using alcohol-based hand sanitizer or washing your hands with soap and water for at least 20 seconds. Be sure to clean your wrists where the edge of the glove was located. Carefully remove the face shield or goggles by grabbing the strap and pulling upwards and away from your head. Do not touch the front of the face shield or goggles. Next, remove and discard the respirator or face mask. If you are wearing a respirator, remove the bottom strap by grabbing only the strap and bringing it carefully over your head. Grasp the top strap and bring it carefully over your head, and then pull the respirator away from your face without touching the front of the respirator. If you are wearing a face mask, carefully untie the straps or unhook them from your ears and pull the mask away from your face without touching the front of the mask. Lastly, once again perform hand hygiene after removing the respirator or face mask. You have now completed the doffing procedure.
So before we get to all this fancy PPE, we first should know what happens to the saliva. So there's a movie called If Saliva Were Red. If you really can make the saliva red, the number of places we touch is going to scare you away, right? So this is a movie that's made by OSAP. So they just did a disclosing dye, and you'll see how many places the operator and the assistant will touch, because just we can't see it doesn't mean it doesn't exist. So you will see the number of places we touch, okay? That's a splatter. Trust me, we do that all the time, right? We don't realize it. And how is your assistant going to go to all those places to make sure that you didn't clean? That's why you need to change our mode of setups. Have a checklist. So you never have to reach the drawer or leave the room. So every procedure is going to have a checklist. So the assistant ensures that everything needed for that procedure is brought in. So you don't take your pinky and open the drawer thinking that the pinky doesn't have saliva. How many times have you gone in and tried to lift a couple of gauze pieces, right? Guilty of that too, right? So now it's going to have to change. You really have to figure out how you can minimize the transfer, how we can minimize the number of times you have to leave the office or leave the operating room, and the number of times you go to the counter to touch any of those things. So the operative setup, and if you look at the surface hygiene, you need to first train your staff for basic setup. There should be nothing on the countertop, right? This is in any time of the day or any time of the year. If you walk into my practice, this is the kind of practice you'll see. There's no reason to have models and the case presentation and the demo and stuff. It pretty much will ruin the areas for cleansability. So you want to have good disinfectant, and we'll talk about what kind of disinfectant. Any area that you're going to touch, you're going to have a plastic sleeve or a sticky pad that will protect the touchpad screens or any of the stuff that you operate. So this is a basic setup. Then what do you do for the chair, right? Am I going to spray this with hypochlorite? Should I spray it with Clorox? Or should I spray it with betadine? Should I spray it with Cavicide? Let's look at what really works. All right, so now I'm going, all these are very common to you. How am I going to keep my office clean? You got Cavicide, you got Lysol, you have Clorox, you have then hypochlorous acid. right? So now let's see if I can get the poll out again, right? So I'm going to see if I can get you the second poll. Which agents have been approved against COVID? What are the list of agents against coronavirus? This is directly from the EPA. You should all have access to this. Okay, I'm going to launch this, okay, to tell you what are the agents that are useful against COVID. So active ingredient, all right? So we will talk about the, let's say most of you chose hypochlorite. You see, hypochlorite is not even listed here. So I'm going to go with hypochlorous acid. So these are all the disinfecting agents that have been used or registered with EPA. These all include your Lysol, your hazmat material, or the quaternary ammonium compound. Again, the next page going to human coronavirus. And what does it say? Contact time for 10 minutes. So you just can't spray, wipe it, and see the next patient. If you spray something, the protocol says leave it there for 10 minutes. The least of it is 3 minutes. Can you imagine if that hypochlorous acid is going to stay for 10 minutes on your nice Belmont chair or a nice Cavo chair or a Clorox? You leave it for 10 minutes. What's going to happen? The whole upholstery is going to become white. So think about how you're going to manage this. It's easy to come up with all these guidelines, but let's talk about the practicality of how we're going to use these disinfectants. This is something that you need to know. So if you are going to be sold something, go to the source, study the chemical and see if it makes sense and use it in the right proportion. Don't go to a bootleg company and say, you know, can you sell me this? I'm going to mix it on my own and start spraying it. Okay, so don't do that. So,
Dr. Iyer,
yes.
quick question.
Yep.
The contact time, as you mentioned, is very important. How does that tie into, you know, some people are doing fumigation, as you know, and they're fumigating the entire office. So how does that tie in?
A good point. So I'm coming, this is one slide later, the fumigation is coming, right? So I'm just going to finish the filtration and then we'll go to fumigation. I'll bring it up. Thanks for reminding me. So let's go to the next poll. Which filter removes the coronavirus best? So you heard about all these HEPA filters, purifiers, right? So you have air purifiers. HEPA is 75% good. And photoelectron, electromagnetic oxidation, PICO, photocatalytic oxidation, right? So another 5 more seconds, I'm going to tell you what it is. Which filter removes coronavirus the best? Okay, I'm going to close the poll. Share the results. All right, so the right answer is none of the above. Okay, coronavirus is not a airborne pathogen. So by having a HEPA, you're really not going to be decreasing the viral load in the office. So, you know, Jim said have one in the waiting room. Why? Because it is a showpiece. It's a conversation piece. Does it do anything? Let's look at how HEPA works. Then you make your own choice if you want to spend money on getting a good HEPA filtration system. Okay. What are HEPA filters and how they work? This is high efficiency particulate arresting factor. So this is a typical HEPA filter that you will find in construction. If you want to have a surgical room, this is what's needed. And they also sell you this where the air will go through one end, it goes through a filtration system and comes through the other. And they all look good. And of course, this is the cute little toy that looks like the Alexa that you can buy in your, for your operatory and tell your patient, this is a HEPA filter that I've got. What is the rationale behind HEPA? Okay, so we talk about air purifiers, right? So this is exactly what Varun was alluding to. So I want to show you this video of how ludicrous some offices have gotten in terms of making their office HEPA rated. Okay, so this is supposed to be a HEPA filter. Okay, just watch. And don't forget, those two chairs are close to each other. Okay, and see the HEPA filter is on this angle, so it's a very nice decorative piece. And this is what we call as social distancing. Oh, well, this is also amazing. See how nicely it's showing up behind the patient when the operator is going to beep. So it has to fly over the operator and go beyond, okay? And this surface is kept open, okay? So we don't have to wipe this. Okay, now we'll see what is the use of, this is the science behind filtration systems.
How do filters remove particles from the air? It's tempting to think of air filters as microscopically small versions of kitchen sieves which block large particles from getting through while letting small ones past. As we'll see though, this picture is rather misleading. Many types of air filters are made from tangled bundles of fine fibers. Together, these create narrow, convoluted pathways for the air to pass through them. For the really large particles, these filters actually do behave a little bit like a kitchen sieve by physically blocking the particles from getting through. But this is pretty much where comparisons with sieves end. To understand why, imagine for a moment a car speeding along a winding road. The car fits easily on the road, but if it's going too fast, it won't be able to navigate the bends, and you just know that at some point it's going to crash. It's the same for small particles speeding through an air filter. As the air twists and turns, the particles can't keep up, and ultimately they end up crashing out and being caught. Because of their inertia, which just like the car depends on how massive they are and how fast they're going, they can't stay the course. But what about the smallest, lightest particles, those that can easily slip along the winding path the air takes? Amazingly, these are also captured efficiently, but for a very different reason. Because these particles are so small, they have very, very little inertia, and they dance around as they're bombarded by the air molecules around them. This rather unusual behavior is called Brownian motion after the first person to observe it. And as they dance, they end up colliding with the filter and being captured. So at the end of the day, it's not the smallest airborne particles that are the hardest to filter out, but the medium-sized ones. Those that are too small to be captured through inertia, but too large to be captured through Brownian motion. And this is why, when manufacturers design and test air filters, they don't use the largest particles or the smallest ones, but they use the middle-sized ones. Those particles that are just the right size to slip through and make it to the other side.
Okay, so this is typically how a filter works. A HEPA is actually a layer of these fibers which are crisscrossed, so the particles that are going to be drawn in should have the ability to be captured by the so-called filtration system. So it needs to have some amount of suction built in, okay? So what do? We go for Google, right? Google is our favorite search engine. And if I put in a word HEPA filter and go to Google search, the first thing I get is an ad. Second I get is an ad. Third I get is an ad. Fourth I get is an ad. And this is WebMD, which is not referenced. And then you're looking at Cover Mega. Do you see any valuable articles of reference anywhere here? I get Target, Home Depot, Bed Bath. They all want to sell me HEPA filters. So this is the lowest level of evidence. So Google, in my opinion, should not be used for verification of information. Google has become too big. They are all thriving on ads. So if you want to do a prospective, randomized, longitudinal, independent, controlled clinical trial, you need to get to the source, to a peer-reviewed journal. So Google used to be #1 in terms of facts, but now it's in the bottom of the rung when it comes to information about these things. So when your eye attracts any of this, you will think, well, Wikipedia is going to be good, let me hit that, but that is not going to tell you what is the use of this HEPA filter in a dental practice. So you're getting carried away by all of these ads that eBay and Amazon gives you, and now you feel, well, this must be good. So if I go to the images and let's see what I get in terms of the HEPA filters. It also tells me all the cost associated with this. And then you'll say, should I get this $299 or should I get a $149? Both say HEPA. Well, mine says Super HEPA, well, maybe I should get this one because it looks taller and it looks bigger and maybe it's better. What is the guideline? We're just going to go through corporate lure, right? So let's see how HEPA works and what is that you need to have in your office to make this really viable. HEPA filters only work for airborne particles. So if there are dust mites, it is in the air. So if I turn off all these lights, you will see particles of dust which are floating, which is less than 0.5 micron. If you can see it, it is no longer a sub-micron particle. If you can see it, it's a droplet or it's a particulate matter. So viruses are sub-microscopic. You're talking about 20 nanometers. Can't even see it. And for it to just float around like that, COVID does not float around in the office. So the HEPA, it doesn't know where the HEPA is, doesn't have eyes to turn around and go to a HEPA filter, right? It can only be landing in a spot because of gravity. So the only thing that the HEPA can actually capture is if you're allergic to pollen, if you're allergic to dust, this is probably going to be helpful in reducing the dust. But don't say I'm using HEPA because I'm going to reduce the viral load of COVID. It is unfounded. Okay, so we need to be careful about that. So because COVID-19 is a droplet spread virus and not airborne, a HEPA purifier won't protect you from coronavirus. It's misleading to think having a HEPA filter is going to be automatically suck all this coronavirus into that unit. And where is it going to? It's going into a cesspool. If it's going to be droplet particles of your breath and sweat and your cough, those are moist particles, which is going into a HEPA, which is only meant for dry particles, right? And now you're going to have a wet filter. Now, would you have a volunteer to go and open up that kit and remove that filter? How often should you remove this? And the company that sold you that unit is no longer in business. Now you cannot find a filter to replace it, right? So don't get into this panic mode. Improve your knowledge base so you can buy things intelligently. So this is my office, the ceiling of my office. This is how most of the construction takes place in the Western world. So it's not feasible in some countries because you need to have ductwork. In concrete places, it's going to be very hard because you need to have higher ceilings. Here, most of it is wood, so we can come up with these drop ceilings. I'm going to show you how a typical air conditioning system works. So this is now a air blowing. Okay, so air is blowing, right? So this is the air conditioning. The air comes out. So this is coming out from here, right here. Okay, so this is exactly where the air is going to be coming out. So if the air comes out, it is going to have certain amount of moisture. It is cold, but it just cannot stay in one place. Otherwise, it's going to be mold developing, right? So you need to have a return. So any air conditioning system should have a return going out. So that's how construction is. So how do you know if the return works? So this is what you need to be looking at for the returns. So we need to go back and see what happens to this other side of my duct. Ready? So if you're going to be using fans, which is a good way to aerate the place, all right? So, okay. Okay, so this is the UVC lights. UVC lights is yet to be proven. So Columbia studies are yet to prove the safety and efficacy. So at this point, don't go out and buy these blue lights because you need to have contact. And don't, for heaven's sake, do not buy the actual UV lights. It's carcinogen. It's a concentrated form of the sun rays. It gets you blind and you get skin cancer. You don't want to put a UV light in your office. It's not protocol. Nowhere in the world UV lights are being used in dental practices. UVC is a nice, decor that you can, if you want to call it, because mind you, the influence of this UVC is going to be in proximity. That UVC that's sitting about 10 feet away is not going to kill a coronavirus, which is already droplet on the floor or in somebody's respiratory system. This is why the joke all came about by putting this UV light inside the body and killing all of these viruses, unfounded. Okay, so Columbia studies is quoted very often, but where was it tested? It was tested in vitro. In vivo studies are yet to come, so until such time, there's really no reason to buy UVC lights. Then we get to fogging machines. Varun mentioned about using foggers. I remember when I was a kid, we used to have these big trucks that had these fogging machines. Did that take away the malaria? No. You know why? Because the puddle that created the malaria is still left behind, right? So you need to go to the source. The fogging is not going to kill the malaria because malaria is not the problem. Malaria is only the vector. Your real problem lies where the source is, which is actually the puddle of water which has been eliminated. And then keep the person who has the malaria isolated. So rather than using these fogging machines, which looks to be quite effective, in fact, it is not effective at all, right? So when we look at the offices, I sometimes look at some of these clinics and say, have I walked into Home Depot or have I got into Stop and Shop? What's being sold here? Maybe the teeth whitening has taken a different flavor. And you see how the fogging machines are still used to disinfect. Please don't do this, right? This is not protocol. Nowhere has it been ever written or proven that you need to spray every surface that is exposed. So this is good, right? Now, what if a patient walks in, he's coming in with the street shoes, walking into your office. So are you going to say, stop, this area is disinfected, and how long you're supposed to stay disinfected, and then wipe the whole floor and then do this all over again? These are marketing tricks, really not scientifically proven to have any kind of effect on reducing the transmission. The transmission is droplets, not on disinfecting areas where there's absolutely no exposure. All right. So this is the data on fogging, right? So virucidal activity of fogged chlorine dioxide. There's a lot of questions on, should I use chlorine dioxide, hydrogen peroxide? Maybe I should put it into a machine and start spraying this and then the coronavirus will be killed, right? So let's look at the actual study. Right, this is the hyperlink to the study. So they're talking about hard to read surfaces, human norovirus, and what does the, of course, we always love to go to the conclusion, right? Because we don't have time to review the body of the article. So at least you should know how they are using these fumigants and all kinds of these fogging machines. And we will see hydrogen peroxide, okay? And this is chlorine dioxide, right? So it talks about all the stuff, disinfectant, right? And then finally, the results say there's absolutely no effect. They didn't observe anything whatsoever, okay? So use of disinfectants does not seem to have any kind of positive effect in terms of reducing the contamination. So you really need to look at quality evidence, and then that is going to give you the clues as to how these foggers work. So I'll be happy to share all of these articles with you. All right, so you can see fogging uniformly delivered the disinfectants throughout the room and effectively decontaminated viruses on hard-to-read surfaces. Okay, so however, fogged chlorine dioxide surface-based product did not achieve time for inactivation. All right, so in vitro, anything is possible because you're fogging right on top of it. But when you talk
about a patient who is sitting in the chair where you're having some interaction, that fogging has already passed. It should be overnight, right? The next day when one patient comes in, another patient comes in, the effect of fogging does not linger for subsequent patients. All right, so now we'll ask the questions on on fans, right? So Varun, is there a question on?
Dr. Shankar, there is a question several people have asked. Is that what about the asymptomatic patients? If there are patients, should this PPE and this standard precautions be followed for every patient walking into your office, or how will you decide?
No, so in an examination, the PPE is your gowns, gloves, masks, and goggles is standard protocol for the last 30 years. That will still be followed whether the patient is symptomatic or asymptomatic. So when AIDS came in, the norm was treat everybody as if they have AIDS, is what we were taught. And we followed universal precaution. Somewhere along the line, we forgot that trend. And we lost the goggles, we lost it. Now we are walking in with no mask. Now is the time for a reset. So even if it's an asymptomatic patient, your goggles, your gowns, your PPE is going to be the standard. I'm not saying to the standard of wearing respirators, but standard of a basic PPE. Now, Ninette, you have come at a very appropriate time. Could you illuminate us or tell us exactly what is happening in UAE? What are the precautions that are being taken, and what are the guidelines that the health authority is following? Because you were once the head of SAHA, and now you are actively involved in patient care. So could you enlighten us as to what is being recommended in UAE?
Dr. Shankar, we are following the universal precautions, right? First of all, we are limiting our practice to doing only emergency procedures. So procedures that we could defer until now, we are doing that. But of course, we have to go back to start our practices. How long are we going to do that? Exactly. So we have to make sure that we have all our proper PPEs available. But before that, we have to triage the patient. So, you will make sure that you've taken the temperature and if the patient has any symptoms or of COVID or not. And there are now, we are very fortunate that most of the patients are being tested. So when they come in, they say, we've already had the corona test done and they are negative, So at least that is a little more comforting before you see these patients. But not everyone. But then you also see the big proportion of the false negative or the false positives. So you have to keep that in mind. So we are treating every patient as you must treat, like when we treat a patient with hepatitis, whether we know they are positive or have hepatitis or not, we treat everybody and follow the standard precautions. We do all the care that we need to do for them.
Right. So let's say somebody needs a surgical extraction and you need to use the drill to section the tooth patients regarding an abscess. So how would you treat these patients?
So then definitely we have to make sure that we have the high-speed suction that is available. You want to make sure that, up till now, we don't want to we want to limit our practices not to have too much aerosols around. But of course, we will soon be having to use high speed. You cannot say that you cannot use any high speed anymore. So we will have to see how we can go around that. Maybe one of the ways we were thinking of using is the 1:5 speed reduction handpiece. Is the handpiece where, the 1:5, which is the slowest handpiece.
That's electric handpiece, but at the end of the day, the electric handpiece needs to be cooled. The same mechanism that is used to drive the turbine is identical. You still need the air to turn it on and turn it off. So the electric handpiece is not like a micro motor, but there's no air. It's connected to an air coupling, which is acting as the activating switch. So
and you need the coolant. You need the coolant for it.
The coolant is an aerosol.
Yeah. Right? So we just have to make sure
that the aerosol is there. But is it like the same private practice?
Yeah. So now if you like, you will request more like cases where you can use the rubber dam. So you want to make sure but not like all procedures, like especially with implant procedures, you have to be careful. You just have to be careful how you treat the patient. So a proper shield, proper masks, and take it from there.
Right. So, I mean, we're all agreeing to the same point, but then everybody is hesitating and coming up with innovative ideas which are unsubstantiated. So, like, for example, pre-procedure mouth rinse. Okay, so what's the best agent? Let's look at what is going to give us the best mouthwash before the procedure. Okay, so I'm going to launch the poll, and it's been recommended that we use peroxide, chlorhexidine, betadine, any of the above, and maybe it's not effective. I don't know. All right, so give it another 5 more seconds. It just shows how little our understanding is when it comes to taking a stance on what to do in our practice. So we're going with the flow, but we need to stop that. We need to address this with sound information. Let me close the poll, and I'm going to share the results. All right, so you can see that 33% felt betadine is good, 26% felt hydrogen peroxide is good, chlorhexidine, any of the above. The right answer is none of them is effective, because think about, where is the virus? Is the virus residing in squamous epithelium, or is it residing in a pseudociliated columnar epithelium, or is it in cuboidal epithelium? So this is a respiratory virus. It won't necessarily reside on squamous. So you can rinse whole day long, and once you spit it out, it is gone, but the patient's still breathing, right? You can't tell the patient stop breathing. So when they breathe, all that virus is still going to come out back into the mouth. So you can't keep asking him to spit every 2 seconds by rinsing. That pre-procedural rinse is good for implant surgery. We are taking that knowledge and saying, now let's use it for COVID too, right? So this is how little we understand about pre-mouthwashes. So again, this is not founded, so I want to prove it to you. This is directly from the ADA.
Well, there aren't any clinical studies supporting
So the question is, all right, in relationship to the rinse protocol, what is the evidence of peroxide or iodine, the top 2 choices that you guys have given?
Well, there aren't any clinical studies supporting the virucidal effects of any pre-procedural mouth rinse against SARS-CoV-2. However, since SARS-CoV-2 may be vulnerable to oxidation, commonly used pre-procedural mouth rinses such as 1.5% hydrogen peroxide rinses may be considered, but considering that the microscopic particles that we are trying to be protected from are coming from the patient's lungs, a mouth rinse is not going to be a panacea unless you're going to have the patient rinse after every breath they take.
Right, so there you have it. So there again, it's not very clear. So this is where it really stimulates your mind into thinking science, right? It is not arbitrarily based procedure. So people are just coming out with guidelines without understanding what's causing all of this. Okay, I've seen chat rooms. So I think it should be 5%. Someone says no, the study says 10%. The fact is there is no study, right? We have not studied coronavirus as a rinse or a pre-rinse procedure. So viral loads, what do we know about viral loads? So let's look at another poll. Okay, so there was a question, I think Varun was asking about the viral load. What is the correlation of viral load? And let me launch the poll. So in terms of the viral load, the higher the load, the lesser the disease, or the higher the load, more severe the disease. The viral load has no correlation. The higher the load, the patient will become more symptomatic, right? So good polling. I'm going to close the poll, 30 seconds, and then I'm going to share the results. Look at the results. A third of you felt the higher the load, more severe the disease. The viral load has no correlation. The higher the load, patient become more severe. So this is the reason when somebody is asymptomatic, they are still carrying the virus. So we used to think, I can take a swab, we can see how many viruses are present in that particular cubic millimeter. But with COVID, the viral load has no correlation with the symptoms. You can be asymptomatic and be a carrier and spill out loads of viruses. So that's another myth regarding, so this is why we are so fearful of this virus. But that just should not stop us from doing what we know and how we can practice safely. So then we get to all these suction devices, right? So now if you Google suction devices, right? So if I kick this up, fish mouth suction devices, extraoral suction devices, you get these beautiful pictures that are coming up. And then what? Ad. Everything is an ad, right? And everybody is promoting something, and nothing from NIH, Henry Schein, Patterson Dental, Scott's Dental. Okay, do you see any NIH, CDC, FDA, PDA? None of them, right? So this is where Google is misleading, right? So you can't just type in efficacy of extraoral suction system and it is pointing to stuff that you need to buy. Am I justified in spending $3,000 on this gizmo, which looks like a space age fish mouth, which is automatically going to suction all of the aerosol production, and it's going to make my place safe, right? So let's look at the video that was used to support this. And I met some of my colleagues and friends have invested in this device, hoping it's going to make a difference in their practice. And the images here is very compelling to see. Well, using an extraoral feature could cause some reduction in the aerosol, right? So this is the aero shield that somebody was inventing, right? So you can see how they have contained this whole thing. The studies have shown you're concentrating everything in that area. And look at the patients breathing right into that aerosol. Not only are you going to create more virus, you're going to cause pneumono ultramicroscopic silicovolcanoconiosis, right? With all this drilling with the plastic, you're going to spill out all this particle which the patient's going to breathe because there is no ventilation. So AeroShield was good on Facebook. It looked like a cute idea, but it's not scientifically validated. So what about these devices, which are very popular on Instagram and social media, right? Should I get this oral backstation, the suction device that is going to magically remove all of the particles? And mind you, if I can see that spray, it is no longer a airborne disease. You can see how the spray comes up. So if using this, you can see the, okay, so it's going up, and what is it? Viruses are droplet nuclei. It still has to go over. The suction is in operation right now. Okay, look at that. It's going beyond, so it's dropping. So how is my assistant supposed to retract and suction? How are we going to perform a surgical extraction when the blood is splattering all over? Okay, so the truth of the matter is, this is a doctored video. There's absolutely no value in buying that extra equipment, because I'm going to show you what we do in our practice. Is a video that I shot just to disprove that extra apparatus. Okay, what you need is this.
This is now simulated drilling.
So this is the high-speed drill. That's what we read about, right? Aerosol, that's not an aerosol, that's a splatter. If I can see the particles of water, that's a splatter. Do you see that? It's microscopic. Right? So what happens now? It disappears. And I take it off. I see that? That is the power of a simple HVAC. So if it's one thing that you want to buy, get yourself a good vacuum machine. Right? So this is what happens when the study is not controlled. Right? So we are buying all of this with no basis. So they should have done a study where there's an extra or basic HVAC and then use the fish mouth. Right? A fish mouth is useless in my opinion because I can get an efficient reduction in my splatter with a simple HVAC. So what should you do? You should go and test your HVAC. HVAC is not saliva ejector. Okay, how do you rate the power of HVAC? Let's see what do I need to do in my office to be open. So this is the ADA mandates and recommendation link. I'll be
Dr.
happy
Aris,
to
sorry.
give you, yes?
A quick question on the
Yes.
suction. Some people are advocating usage of devices like Isolite, which hooks up to the suction. What do you think of Isolite or similar devices?
Isolite is a good way to isolate, and suction is very good, but there is no substitute to HVAC. Isolite is a good static device for isolation to get a dry feel, but the Isolite by itself will not be able to capture a contralateral drip or a aerosol particle which is coming out. Right? So it is a good adjunct, but you still cannot do without the HVAC. Isolite, Mr. Thirsty are all good devices. I'm going to show you what the Isolite looks like since you brought it up. Yeah, it's a good way. Right? So this is a good way to kind of keep the area dry. Very nice. Right? So this is there, but then you can have splatter beyond. Okay, so you can have this completely occludes, but from the contralateral aspect, this is how it looks. You can retrofit it, but I would still use a second carrier just to be able to get the additional splatter off. So typically I have outfitted my practice. This is a good way. So what happens when something goes out from here? You don't want the tongue to be caught. So this is a good retractor and a good visually appealing device, but then you still cannot live without the HVAC. Okay, so let's go back here. So ADA mandates and recommendation, the link is there. I'm also going to please download the handouts. I've added 3 new handouts. So this is all I've done in my practice. Okay, if you came today, this is what I would do, and this is what I've been doing for the past 6 or 7 years, from the time that we were into maintaining the upholstery and not really spraying my upholstery with this Clorox and all kinds of disinfectant, which actually makes my entire upholstery discolored. Okay, so we don't need to get to that level because you're not picking up anything from the chair. The patient's coming with street clothes. You're not giving the patient a new gown. So street clothes with a disinfected surface or something that is covered is good enough. So the only change I've added, because I do have a containment, is to add a second suction to this. Okay, so all we did was just add another HVAC. I've got one HVAC, which is going to be adequate, and I have another HVAC and a saliva ejector. And then this is the retraction valve. It has its own, little area to kind of make sure that the water line that comes in is filtered. Okay, so you don't need any special UV filtration system. This comes with the chair. Okay, so these are the basic evacuation equipment, right? So you have a saliva ejector, a surgical tip, a larger surgical tip, and HVAC. Okay, which amongst these you think is going to suction the most? Okay, we'll see what would be the ideal suction. So this is 1 liter of water. I'm going to time this with a high volume evacuation that I have, that I just showed you. So let's see what happens.
This is the test of efficacy of our high volume evacuation. 3, 2, 1.
So it takes about, touching this, 10 seconds, maximum 11 seconds.
So that took about 15 seconds
with everything
to
together.
suction
Okay?
1 liter of water. And I'm going to compare this with the saliva ejector.
Right, so you could see how effectively in 10 seconds, 12 seconds, it's completely gone, 1 liter, okay? So if I'm going to do surgery, and if I'm also going to use a high-speed air order, right, so let's see what the saliva ejector does.
This is the traditional saliva ejector, 3, 2, 1.
It's like waiting for the water to boil. Right, you're just going to sit there and watch. So there is no way this has any kind of power to create the elimination of the aerosol.
See how inefficient the saliva ejector is?
I'm going to fast forward because you don't need to see. You all know how the saliva ejector sucks. So I'll show you the timing. Okay, so now it's almost
a full minute.
Okay, what about a larger suction tip?
These are 2 surgical tips, and I'm going to show which one's more effective in terms of suctioning surgical debris. 3, 2, 1.
Again, you go on. You don't need to see all this. So that takes about 40 seconds.
Almost as bad as the
40 seconds.
So it's important that we understand these.
Let's see the thinner one. When you want to go into a root tip, or if you want to go to an episectomy site and you want to suction that.
This is the fine tip surgical suction.
All right, so
it's clear. Then
I can go on
now.
So I'm still suctioning.
Fine surgical tip.
1 minute is over, and it's still now
going to take
suction ending
2 minutes. And we still have.
So you need to calibrate your suction and high evacuation equipment. So have 2, which is always good. So instead of 4-handed dentistry, now you may be forced to do 6-handed dentistry because it just speeds up the entire process. Okay. So how do I protect the front office staff and clinical staff? Okay. So it's important that we practice physical distancing. Yes.
Question on the suctions. So for the HVAC, you need a separate suction motor, or there's something called a pneumatic system where the compressor is used to drive the suction, the compressor is used in reverse. And then could you also talk a little bit about wet and dry suction systems and which is better?
Right. Okay, so this is typically what happens in a suction system, right? So you do have a Venturi principle. Okay, so you have water. If you remember the Venturi principle from your physics stage, the water flows through this Venturi tube, and because of the flow, you have the water rise. So if there is a puddle of water, because of this flow, this is going to get sucked in. That's a typical Venturi principle. That's what most of the vacuum machines use. That is a wet vac. The wet vac uses a lot of water. Your water will be very high because of the flow of the Venturi, which is what most of the offices will generally use, will use the water principle to actually cause the suction. It's not as good as your dry vac, where you have the actual motor that runs to bring in the air or the water to suction. So there's a constant flow in the absence of the water to create the suction. So that's what is called as a dry vac. Dry vac is twice as expensive as a wet vac, but then when you amortize it over a year, then you save on the water bill, right? It also is less maintenance. Your upfront cost is more, but it does require oil, right? You have to make sure that it runs. So you can't really use a compressor in reverse and expect the suction to take place, because it works on a completely different principle. Your motor, if it goes in reverse, will only help the turbine spin a different way, right? So I was going to take pictures of my suction that is downstairs. So maybe in the next webinar, if there is an interest, I can
break it down into the actual components that you need to buy if you're outfitting your offices. So I would prefer a wet vac over dry vac over a wet vac. And then when you talk about the pneumatic, that again is not as powerful as your Mojave or one of those dry vac machines that is available. So I know in India there's a lot of durosuction, but you must figure out what is the horsepower of those machines. You can't have a quarter HP and put it to 6 chairs, right? So you really need a 2 HP or a 3 HP with multiple heads to be able to give you the ability to suction effectively. All right, did that answer the question, Varun?
Yes, very much. Thank you.
All right, so let's practice physical distancing, face covering, mask. Okay, you need to make sure that the keyboards are all covered. Gowns is not recommended for the front office. Okay, I was looking at all these barriers, right? This is Stop and Shop, Target. So I took these pictures and I was thinking, what are these barriers supposed to do? So in the event that you cough or sneeze, it doesn't really connect with the cashier. Guess where the transaction is? The transaction takes place after the barrier. That's where your checking counter is. Look at where they have positioned all of the credit card machines. So she is actually directly looking at the cashier, and the shield is basically a decorative element. So again, don't go out and buy expensive plexiglasses and have these barriers in front. What you need is a good face mask and a shield that is better than any glass barrier or these kinds of plexiglasses that you can have in your offices. So this is what we have in the office. It's a basic, shield. We have a mask, and this distance is the distance that you would like to have. So when you design your office, make sure that you have your check writing counter. It comes down, and this is another 2 feet. So she sits 1 feet away. So this distance to the patient, right? So this distance to the patient is at least a minimum of 5 feet. And the patient is really not leaning over anything. And if you look at the temperature control, okay, and then every patient is given their own pencils. And these days, they are asked to go online and do all of their registration. This is my standard operating protocol. This is what I am doing. As of yesterday, this is the protocol before an implant surgery. Okay, so do I have aerosol? Sure, but look at my suction that is there. I'm having my auxiliaries cover their face. And of course, do I need a head cap? No, but it is okay to mix to feel better. And I have a disposable gown. So this is fair enough. This is good enough because this is the level of protection I'm affording to myself, my staff, and you can also see the response from our patients. So do I really need any of these big N95 masks, which I don't know where I have it? So let's say you place, those respirators that you're talking about. So this is the respirator that your friend is wearing. Okay, so when you have these respirators, the amount of usage for this is supposed to be a single patient use, because to disinfect that, it's a one-way stream. All right, so you can prevent all of the elements from getting in, but getting out is a valve, right? So if the valve is not going to be effective enough to produce a seal, then you are breathing out your own contaminated air. So there is a problem in how this is being used. This is good for areas where you see poisonous gas or any kind where you don't want to inhale anything, but you can exhale whatever you need, because there has to be an exit point. So it's a one-way valve, but when it exhales, that is not filtered. It goes right through. And that's what Varun was trying to say, that if you have somebody with COVID wearing this, you're in fact infecting your assistant who is very next to you. So with all these equipment that you see here, the one that I use as my standard operating procedure is this surgical mask, and I have this shield, and that's pretty much what I'm relying on at this point. Okay, so we don't have a single instance of a patient contracting COVID from a dental office, nor a dentist transferring to a patient yet. All right, we are all sensible people. We mean well. We want our profession to maintain the highest standard of care. We cannot deviate or depart from the standard of care, and it's vital that we provide the finest of treatment a patient deserves. Delaying treatment is only causing harm. Why would I leave a renal disease to just stay there and not use Cavitron? And this is a mistake that the whole hygiene fraternity needs to really understand and partner with us to make sure that the patient gets better. Everybody's talking about the Cavitron causing an aerosol, and the aerosol is going to be infective. Guess what? That is what they've been using for the past 30 years. They've been treating patients with AIDS. They've been treating patients with SARS. They've been treating patients with H1N1. They've been treating patients with hepatitis B, C. Now, all of a sudden, this corona comes in and everybody has to stop practicing, right? This is fear instilled with very limited knowledge. We are better than any of the scare tactics that is out there. If you want to excel, and if you want to be in the forefront of medicine, we need to arm ourselves with a lot of information and practice dentistry that you can hang your hat on. Nobody can defy or deny your rights as a dentist to practice the best of dentistry. But look at yourself, see if you are equipped enough to manage the situation. I don't want any of you to get sick. This was not intended to actually make you work. This was intended to give you information so that when you do start to work, you have the necessary armamentarium to protect yourself, your families, your patients, your staff, and the community at large. So I think we are slightly over time, but I would be happy to entertain any questions. I want to thank Net and Varun for efficiently managing all of the information here. Varun, special thanks to you for providing some of the videos and also being interactive. We should actually make this into a series of videos that can help dentists establish their practice in a normal and a safe and effective manner. And it's not product based. There's not 1 cent that you have to invest from this entire information, right? This is solid knowledge that you are going to take home and revisit your own practices and do a self-assessment and test yourself and see if your practice is ready to receive patients, right? We can all either be miserable and worry about it, or be happy about the fact that now we have more information. We are now ready to begin with a fresh breath of energy. So that should be the attitude. And I know all of you are very smart. You're all very talented. Don't let your talent go for waste for lack of information or lack of understanding. Any questions? Yes, Varun.
Dr. Iyer, one of the questions is, should we close off the toilets to the patients?
Oh, we should close off toilets. I mean, you know, this is not an orophycal route. If you say hepatitis A pandemic, then I would say close up the toilets, right? There's absolutely no reason to shut your hygiene areas. Where will they go? They're going to be in your practice for 2 hours. They need to go to the bathroom, all right? So if this was a hepatitis A problem, then I would say close your bathroom. This is absolutely safe. There's no basis for closing the toilets on account of COVID. It's baseless.
Dr. Shankar, another thing that you, observing, you know, that you have a lot of these people moving around with gloves in their hand, wearing gloves all over the place. What's your take on that?
So when you are about to leave the room, that glove should come off. In the hallways, there should be no gloves. The only thing that should be on you is your mask and your head shield. Otherwise, they should not be seen in any common area with gloves of any form, sterile, non-sterile. Once the patient contact is over, the gloves come off. And then the PPE comes off, and then you can choose to leave the headgear till you see the next patient, because that is not a one patient use. So
no, what I meant, yeah, we are seeing a lot of people walking around, patients, you know,
I'm sorry.
in the office wearing gloves. Yeah, in the public way. So what do you say on that?
Okay, you know, so if I'm going to a store, it's a good point, because we've seen this in the US all the time. So if I go to a store and I'm going to buy, let's say, something that is in an aisle with, it's got a nice polythene sheet,
I don't know whether the guy who put all those scans sneezed, or if the guy who was before me was infected and touched an area. I don't know. So people are worried if they touch something and their hands could now get infected. So that's the reason why they are wearing gloves. Well, this is again panic, but I'm not saying you should not wear it. You will not be found fault with if you wore gloves to a supermarket. Right? Supermarket is still an area where a lot of handling takes place, a lot of exchanges take place, a lot of keypads are there, but you don't know. Unless and until we have a vaccine, we should follow universal precaution, but don't drive ourselves crazy by, isolating ourselves entirely. Right? So it's good practice to have hygiene. The problem is you fear what the other person is not hygienic enough. So you're only trying to protect yourself when you go to supermarkets and you go to a public place where you have to touch something, and that's the fear. Again, touching does not cause infection. This cannot reside on your hands. The COVID virus will not penetrate your keratinized mucosa. It can only penetrate respiratory mucosa. If I cut my finger and soak my finger in a bowl of COVID, will I get COVID? It is not a blood-borne pathogen, right? You need to have, it is by a virus, by definition, is an obligate intracellular pathogen. It has specific target areas it has to go to. So by the time you are touching something, you go to rub your eyes, there you have a good chance that the virus could get entrapped into a mucosa, which can cause tearing, and that tear goes into a nasolacrimal duct, and that in turn can affect your respiratory mucosa. So, I mean, this is what we see all the time, and there's no way to stop it. I mean, you also cannot really recommend or provide any kind of documentation to say the use of gloves is going to be helpful or not helpful. So, good point, though.
Your thoughts on reusable PPE, meaning autoclavable or washable PPE, just so that there's less of an environmental impact?
So then the onus is upon the owner of the practice. If you're going to use a reusable PPE, like a nice starched uniform, I'm going to try and see if we can get it. Can I get one of those gowns, please? So there are jackets that are available, which is Scotch Guard. You can reuse them, but then the owner of the practice should take responsibility to have a laundry in-house or have a laundromat service or a uniform service that will help the turnover of all of this gowns. So if you're using reusable gowns, then it should not leave the premises. They cannot wrap it up and take it home and put it for wash, right? So everything that happens in the office stays in the office. Nothing gets carried out. That's the reason why we would want you to come in street clothes, come to the office, change, treat the patient, remove, discard, go back into your street clothes and go home and shower. Until and unless we have proper guidelines, this would be the protocol. You cannot, we used to come in scrubs into the office. That's not going to happen anymore. If you're coming in scrubs from the street, you got to change it. Or if you're wearing street clothes, then wear the gown over that. So you can't really do your laundry at home, given the current situation. So this is now the kind of reusable gown. Okay, so we could see whether it's going to get stained or not. So if I put water on this, right, you can, I don't know if you can see it. So I'm having water inside. It should not penetrate through and it should run off. Okay, so if I have splatter on this, it shouldn't touch. You can see the droplets, right? So the droplets that you see there means that the surface tension is very, very low, so it just rolls off. So this could be a reusable gown. Again, if you see a visible stain, then you got to change it, right? You cannot walk around from room to room if you see some blood stains or if you see some splatter of a trophy, right? So reusable gowns are very, very tricky, very heavy. So I would keep that mainly for restorative procedures. If you're doing a filling here and there, if you're doing a checkup, if you're doing a denture construction. So think about the procedures you're doing and adorn yourself according to the procedures that is going to be requiring the use of isolation. So if your assistant, if your hygienist is going to do a Cavitron scaler, so give her something that's disposable. She cannot walk around with this, with all the splatter on her gown and go from room to room. And besides, patients have periodontal disease, it's going to splatter blood. You're going to see a trickle of blood. It has to be changed, right? So it's very difficult to really define to what extent it can be reusable. Did that answer your question, Varun?
Yes, very much. But there's a follow-up question on HVAC.
Yes.
Yes. One of the things is suggested is if you have the air conditioning on, you should be opening the windows and keeping the fan going. That's one option. And then the other option is to install a HEPA filter onto existing air conditioning. What are your thoughts on both of that?
I'm going to show you exactly what's happening. There's something like this head chair tower, cut up small piece. So I'm going to show you the way air conditioning works. Okay, so you must have, I mean, all of you have stayed in nice hotels, but you've seen you've probably smelt a musty odor in some hotels that have AC. And when you look around, those hotels don't have a return. So the AC spits out all the cold air, which is moisture laden, and goes and lands on carpets and your bed. So when you sit on the bed, it sometimes feels moist. The problem with these, its AC is a one-way stream. It just spits out the air. There is no return. So you need to have a return to be able to take that exhaust out. So if your office has only an air conditioning, you need to find out from the company if they do have a recirculation system. In the absence of a recirculation system, you need to open your windows to allow that moisture to go, and also it's a good circulation within the office. So that's the reason why somebody is recommending that you open the window while the AC is on, because it also protects your equipment in the office. Otherwise, it becomes musty. You can see the moisture-laden surfaces, and also the walls start to create mold. So AC can be having a cooling effect, but if the AC is not supplemented with a return, you're going to end up with a lot of moisture, and that is not good. I mean,
so how is it for the ACs which we typically have in India? For example, they are either split or cassette, or they're window ACs. Do these have a return, or are you only talking about like centralized systems?
So no, these units can also have return where you can turn. There's a setting that you can have. So when you buy new ACs, they do have a return, which means they take the air from outside and they take the air from inside and push it out. So you have the setting in many of the recent models of split ACs, where they not only send out the cold air, they are able to take this back in return, and there is a timer that does it. So in your remote, you can set it for circulation mode or AC mode, or one of those modes which will take the return back. I can get you some information on this. I'm not sure if it's available for purchase right away, but why don't you do some research in India? I will send you the information that I have here, and we can compare notes and see what would be the best AC system that is good for a place where you don't have any return.
That's perfect. Thank you.
Yeah, so I know there's a lot more other questions.
There's another question. How long can you use the N95 mask for?
Okay, N95 mask, people have come up with UVC, UC and all. So if I have this with a actual stain
filter
with blood or a splatter, there's no way to remove that. You can put hydrogen peroxide. Why would I want to breathe a blood-laden mask, right? So this is for construction purposes. Where do you think N95 came out of? N95 came out of construction in 1952. 1952, there was silicosis. People went into coal mines. People were getting all kinds of asbestosis. So to prevent the inhalation of asbestos and all kinds of these airborne respiratory disease, they brought this mask. This mask was a triple layer. The guy who made this is still alive, right? So they have these multiple layers. I'm going to actually show you what the N95 has. It has 3-4 layers. right? 1 layer, 2 layers, 3 layers, 4 layers of this is on. So I can even break this off and show you what exactly that is. So if you see this, it's very difficult to go through and through. So if there is a splatter, right, you cannot autoclave this. If it soaks through and goes into that opposite end, it's done. You can't really use it again. So if I have powder particles and if I have something that I can clean off, that's okay. So what's the point in putting it under UV light? Okay, I can turn on the UV light. UV light only kills the bacteria but doesn't take away the proteins. The protein is a contaminant, right? And it doesn't have the power to penetrate through the mask, into the layers, into the deep parts to actually remove the cell in which the virus actually resides, right? So it's very tricky. Sterilization, there are certain protocols for sterilization, but that is only disinfection. I wouldn't call it sterile. I can't throw this into an autoclave because the glue will come off. It won't fit anymore. This will warp. And once the moisture of the autoclave goes in, this whole thing will get destroyed. So it's not meant for autoclaving. You can only do any kind of UV filtration or some kind of a gamma radiation is what you can sterilize this with. But as is, it comes in a box. I hope that answered the question, Ninette.
Yes. So technically, of course, if it is soil, you would use it, but you can use it for a couple of patients, provided it is not soil.
That's correct. Exactly. So I would say, a day or two, a day at most, yes. But remember, these masks are worn for a whole week by medical professionals. And what do? They just go say hi to the patient. They're not intubating. They're not drilling. They're not doing anything that is producing aerosols. So if I'm going to see a patient, I'm going to do cavitron, even though I have the HVAC, some particles can go and attach themselves around the mask. Or if I'm not walking around with this 24/7, I got to remove it at some point. So if I remove it, where am I going to place it? I'm going to place it somewhere, right? So to sterilize an N95 is a far-fetched idea. You can disinfect, you can try and keep it clean, but the $6 is down the drain if it gets, yeah. So this is the N95, original N95. Okay? This is a duplicate N95. You can see the difference. It should say 3M. In fact, I do have a few cases which I've been sharing with my colleagues. So this is how it is. This is not sterile, right? So if I'm going to do a surgical procedure where I have to do a sinus graft, or I'm going to do a segmental osteotomy, or I'm going to do some ridge split, am I going to wear this? No way. I'm going to stick to this. This is what I'm going to do for all of my surgical procedures. I can take this off, and it becomes a one-time use. It's not financially viable to have it, reused. Okay, any more questions?
I think we'll have never-ending questions, Dr. Shankar.
No. There's a lot of questions I see, and we probably should be, what would be nice? Let's see what else is there.
So what would be nice, Dr. Shankar? We can have one session and, give them points like, this is thing that we can do in the office, now that you've covered all the overall background,
okay.
1, 2, 3 is the suggestions or recommendations.
Right. So this is only to whet the appetite. I didn't get into the details of the mechanics of it, how to take the HEPA filter apart, how to actually look at the suction equipment. We can do this as a part 2, as an extension, and I'm sure all of us can collaborate. And I want you to give me real life situations as to how to handle this, and I can take a video of an actual procedure that we do. We are open for business. We're seeing patients, and I have a lot of feedback from patients that I'll be happy to play here. But I think we've gone beyond our time. It's now 12:45. It's almost like 3 hours and 15 minutes, and everybody's still quite actively interacting. So anything else, Varun?
Yeah, do you really want me to continue? Because we can go on forever. So if you're okay, I can keep one of the questions is on. We can take one final question, I guess, which we've not heard on this topic before. one question is, should we advise patients for a pre-test on COVID? Because there are some places which are doing rapid antibody testing in 15 minutes.
Okay.
But
so
it's
all
not
these
very...
tests for COVID is now going to be thrown out because I take a test now, right? I'm going to a supermarket. I get infected. So just because I'm negative doesn't mean I have negative result for life, right? So this is a very ironic. That's why we stopped testing, right? So why is the rate so high? Because we are testing left, right, and center. So countries that don't do testing don't have to show they have cases, right? So there's a negative and a positive, lot of false positives, lot of false negatives. There's sensitivity and specificity. So both of these are affected by not only just the valid testing point. Now we are going after antibodies. There are only about 2 companies that have been approved for antibody testing. And the best center for testing antibodies, where do you think it is? The dental practice. The dental practice is the best way to have a complete test for antibodies because we're looking at the mouths all day long. It's a simple prick test. You can verify in 5 minutes if the patient has antibodies or not. And then you can say you're ready to start treatment. So this is work in progress. That was going to be my part 2 of my presentation, but I can give you some overview of what exactly is going to come. You can get the results in 20 minutes. This is approved by the FDA. If this happens, then all a problem is partially solved. I'm not saying completely gone. It's about $16 for each one. And in the US, the government is going to pay for these tests because this is a valid test and the rate of sensitivity is very high. So we as dentists can feel much safer if we are going to bring in tests in our practice. So I can give a whole presentation on identifying these antibodies, the problems with COVID testing, what we need to have in place, and how we can make this very meaningful for our practices and not worry and fear that the next patient that's going to come is going to infect us or not. There are different levels of the antibody susceptibility, whether you have active disease or whether you have developed immunity to this, right? So this is the next part of it. It's easy to use, and you can see the different line. This is the control line. This is for the IgG antibody. This is for the IgM antibody. So all they need is to do a prick test, and you will have the answer within 10 minutes. So it tells you positive results, negative results, and invalid results. Right, so I'll be happy to do a couple of tests once the material arrives in my practice. So we need to be in the forefront. Do not worry, do not despair. We are in the driver's seat, I should say, because we know more about infection control than any of the physicians out there. So don't panic, all right? Nobody's going to die. The few people that have died have blamed on COVID. They have comorbidity, right? It's okay for a dentist to die, but if they have heart attack, you can't really always say, well, COVID took him away. I can also cry. My sister passed away, right? I could, moan till there's no tomorrow, but I have to get up and find out what exactly has happened and how I can help my community to not be affected by this COVID. Okay. So with that said, I would like to conclude. I want to thank you for your patience. We have over 700 people at one point attending the webinar. And anything else, closing words?
Thank you very much.
Thank you, thank you, Dr. Iyer, for your time. It was fantastic.
Thank you, Ron. Really appreciate it. Thank you, Ninette. I think the three of us should come back and look at the science. And I hope you guys will not be in a mode of panic attack and go changing your offices and buying some expensive equipment. There's absolutely no need at this point. And I'll keep you updated, and I'll be happy to share a ton of literature that I've accumulated. I can send it across by email me personally, and I'll be happy to share all of this. Nothing is a secret, okay? Thanks again, and have a wonderful weekend.